small for size graft into grade A, B, and C. So grade A is pre-small for size, where the bilirubin at day 7 is more than 5, or ascites is more than 1 liter. Grade B is bilirubin more than 10 or INR of more than 1.6, or at day 14, bilirubin of more than 10 and ascites of more than 1 liter per day. And and they also sort of try to tell how much graft loss you have in each. And grade C is obviously advanced liver failure with a bilirubin of more than 20 on day 14 with a very high graft loss. So our patient probably falls in grade B. He has a bilirubin of more than 10, ascites of more than 1 liter at about 2 weeks. So what are the risk factors, donor and recipient? Dr. Saigal, so can you please tell us what are the risk factors for small for size in terms of the donor and the recipient?
Yeah, I think that's very important to discuss. I was also thinking in my mind about that, definition of early graft dysfunction. Maybe we can catch up later. I thought that what we're following today is again that, old criteria with Kim Althoff has given for DDLT. Maybe you will probably discuss later on.
Yeah, so, I mean, I had that here, but I didn't talk of that. So that's a little different. DDLT criteria are a little different.
Yeah.
And LDLT, and especially now that we have the new ILTS guidelines, I think probably that's better to follow.
Yeah, exactly, that's right, yeah. So I think this is a very important point, donor and recipient risk factors. We always try to identify, but mostly so retrospectively you try and see what's happening. In my opinion, if I have to ask, if I think and say which are the important factors, perhaps elderly donors is one. No, those who are 50, 55 plus. Secondly, those who are steatotic grafts. Perhaps, we have a tendency of, increasing our, like acceptability, 10%, 15%, 20%. But I think that those grafts which are steatotic beforehand are more in LDLT, likely to have dysfunction in the recipient. Then, if we are giving a GRWR which is less, again, we are trying to do up to 0.7, but sometimes you have 0.65, 0.6. Those are definitely at a high risk. That's, a feeling which I've got. In the recipient side, yes, if you have very high portal hypertension, like you rightly said, this patient had 24 as portal pressure, and then, Dr. Swain would have done an inflow modulation as a hemiportocaval shunt. I think that's a good policy. So very high portal hypertension in recipients. Also, those who are very sick recipients, very high MELD score, ACLF patients. We are again, entering into that field where we're not saying no easily, we take tough cases. So our very high portal hypertension, very sick patients, high MELD score, and, perhaps pre-transplant renal dysfunction and sepsis. So these are the things which often are in my mind, but again, they are retrospectively, prospectively, when we have a patient, we know this can happen, but they will not preclude me from going ahead, but we'll have to be very cautious.
You know the risk factors, but you don't probably stop the transplant because of those.
DDLT, cold ischemia time.
Yes, DDLT definitely.
For fatty livers, cold ischemia time is one of the worst.
Yeah, so again, this is just a table to summarize the recipient risk factors and the donor risk factors, which Dr. Saigal already talked of. The ILTS guideline has again now given a specific value for the donor fat at 20% macrovascular steatosis. So anything above that, higher chances of having a small for size graft. Dr. Manish, how important is GRWR? Now, this is a very controversial thing. I mean, world over it has been, we have been taught and we practice 0.8. There are a lot of centers now where Dr. Saigal works. They believe that, probably, and they've published also, that, 0.7 or 0.6 is also equally good. You don't have any small for size. So what's your thought on it, and do you think, does it matter? The GRWR.
No, ideally they've mentioned that GRWR more than 1 is the best, which is not actually possible in all cases. Or if you're actually more than 0.8, young donor, no steatosis, fine. And there is another criteria, you can go below 0.8, maybe 0.6, 0.7, provided the donor is less than 35 and the recipient's MELD is less than 15. Now in our case, just the only thing which went against probably was the MELD of the recipient was 17. So like GRWR does matter, but we need to know the state of the graph which is coming. And portal pressure modulation is actually important because any, like when we do CT volumetry, the ratio has to be more than 35 of the graph volume as well as standard liver volume. And the portal flow of 100 ml per milligram per gram of tissue per minute is required for regeneration. So anything which goes beyond 200, 250 will actually present like small for size syndrome. So GRWR just does matter.
Yes, so this is what the new ILTS guidelines also say, that for a very sick patient, ALF high melder, you should have more than one. All cases 0.8, 0.6 to 0.8 in selected cases, low meld, not very high portal hypertension, and 0.6 or less is not recommended. So I think what the ILTS guideline has used is a meld of 19. That is what they have called. So lower than 19 is low meld actually. So according to that, this patient 17 was probably okay for 0.7. But anyway, that's that's a moot point. So now obviously we know the risk factors, the donor risk factors, the recipient risk factors. Now, and obviously you can choose a better donor. But like Dr. Saigal said, you don't have a choice most of the times. The patient has a meld or whatever he has, you can't really decrease it. That's why you're transplanting him. So what can we do intraoperatively to prevent small for size graft?
Actually, the problem arises when on preoperative evaluation, a GRWR is good. It's 0.8 or more. But suppose intraoperatively, the graft retrieved is of lesser volume given on volumetry, and you end up having a lower GRWR, say 0.6 or 0.7 or 0.75, whatever. So there comes the role of some portal flow inflow modulation per se. So basically, portal inflow modulation can be based on subjective or objective criteria. Different centers have different ways of intervening or doing it. So as far as subjective criteria lies with the surgeon's prerogative, whether if he feels that his spleen is too large or basically the portal flow is very much, and after perfusion, sometimes you intervene even after perfusion. If the graft consistency is very much turgid or so these are all the
what would you have done in this patient? Would you do
in this particular
shunt?
case,
would you do splenic artery ligation or
I
nothing?
would have preferred a splenic artery ligation in this. Because
I think that's a center-to-center experience and variability.
So, my preference would be first splenic artery ligation, and usually because in my particular experience for a right lobe graft, usually doing a shunt would be too much, and sometimes it's very difficult and tricky business because shunt can steal the portal flow volume from the graft and can have disastrous consequences.
Yeah, you can have a steal.
Well. Yeah, so it's a very calculated.
So modulating inflow, like Dr. Vishal said, mostly by either splenic artery ligation or by a portocaval shunt. And I think we are running late. And these are the strategies which we spoke of. So a portocaval, hemi-portocaval shunt, splenic artery ligation, splenectomy, these are the options which the surgeons have intraoperatively to prevent a small for size graft. And this is what again the ILTS has recommended, that it is mandatory to achieve a post-reperfusion pressure of at least less than 20 and ideal to less than 15. So what we follow is if it's more than 15, we generally do a hemi-portocaval shunt, and we published this a few years ago in liver transplantation where we showed similar results with a lower GRWR and a hemi-portocaval shunt as compared to the control group of a good GRWR. So Dr. Naveen, now we know this patient has small for size graft. He has a bilirubin of 15, high drain output. What's your next step? How do you manage him?
So of course, we need, first of all, as physicians, we need to anticipate that this is going to happen with the patient. So this injury is in the first week, and unfortunately it manifests in the second week. So we need to start taking actions beforehand when the drain is increasing, give a lot of albumin, keep them on antibiotics, make sure they don't get infections, be very mindful, good nutrition, and keep the immunosuppression a bit low. Of course, there is no guidelines for immunosuppression, but keep it as low so that they don't reject. And if you ask me, if you once you've done a biopsy for this, you'll know that there is no rejection, so that you can go lower on immunosuppression as well. And also, such patients who are really sick do not generally reject. So we need to keep the immunosuppression a little low, and you also have therapies like somatostatins, and you can do plasmapheresis early on so that there is no graft failure and more chances of infection. But nutrition, albumins, and the general management because there is exponential increase in the bilirubin. With cholestasis, the tacrolimus level jumps. So you will need to
so I think
keep that, all these
absolutely.
things.
So I think managing nutrition and probably keeping the immunosuppression a little low. Eventually, you have a cholestatic graft. Eventually, they become septic, and usually that's the that's the cause of death in such patients. So, like you said, there have been trials on NAC, prostaglandins, plasmapheresis, but really nothing IVIG. But there are all just 1 or 2 case studies or very few patients, and there is really no major role of any of these. Some centers do a splenic artery embolization. I don't know, Dr. Vishal, do you do it? So one is prevention intra-op, but would you do a splenic artery embolization after?
Yes, of course. If in post-operative encounters a scenario and which fits into the syndrome, then we.
But again, there is very little data on any of these modalities. Dr. Saigal, yes.
Yeah, I just want to put that splenic artery embolization. We had a very good, interesting case recently. He had a graft dysfunction with which criteria we follow, and the hepatic artery flow was not seen very well. And we were really confused what's happening. Then we actually realized that he had a steal phenomenon, and we actually did a splenic artery embolization on day 4 or day 4, and realized that post-procedure, next day the artery was seen very nicely. In fact, it's a small case report which I'm trying to get through. Maybe as a surgeon you will be able to tell us better.
Small for size, we usually say it's because of portal hyperperfusion, but it's a different view to look at. It's because of splenic hyperperfusion as well.
That's right.
So it's arterial hyperperfusion. So if you can correct that, then obviously it leads to betterment of small for size.
Plasma exchange, Dr. Saigal, what's your thought and experience on that?
Thank you. I mean, that's a really tough question because
and we are almost out of time. So
yeah. I tell you one
quick answer.
In the MCLT meeting on the consensus, when all the modular discussed, and actually I realized that plasma exchange was not mentioned in that therapeutic arm. So I asked the question, what about plasmapheresis? And most of the people said, oh yeah, we can, we may not. So I realized that it is not so well accepted. But in my own practice, and probably we belong to the same place, I think that those who are sick, bilirubin is crossing more than 20, graft dysfunction, not responding, no sepsis, nothing. I think that there is a definite, at least one should try plasma exchange, plasmapheresis in your patient. We have small experience, I won't say we have done a lot of patients, very few, but yes, in a given patient it can work, and no patient should be advised of reality without trying. In today's I think maybe Neeraj will agree that we probably would have a scope.
Yeah, so I think of all the the so-called modalities we have apart from supportive treatment, probably plasma exchange does work better than, but doesn't work. Our experience is that I think we've done it in about 20 patients, we've saved about 6 or 7, I think. So maybe 1/3 of them we have solved.
I think it's come as a saving grace more than anything else.
So there are some papers, especially one from Korea, SG Lee, in which they have shown a significant improvement in patients who underwent. So this is what we did in this patient. We did 5 sessions of plasma exchange, and the bilirubin on day 26 came down to 6.6, and then further the patient actually had normal LFTs, and we were able to salvage this patient. But again, I'm not giving a message that it's something which is recommended. Like you said, it has not been really talked about in the ILTS guidelines. But I think it does save some patients, maybe 25-30% patients you can save with this. So this is the post-operative course of this patient. This patient eventually recovered, and he is doing well till date. Just one last question. When would you consider retransplant in a patient of small for size? Because what we have seen is it's because you obviously can't advise transplant on day 14, and you wait, and when you wait, they become septic, Obviously, the logistics are different, having another donor and the money and all that is separate. But most of the times, the patient is not fit for a retransplant.
Yeah, it's a case 22 situation actually. Retransplant usually in such scenarios are indicated for early graft failure. Unless there is graft failure, there is always a scope for recovery. So, but having said that, once graft failure sets in, then there's a lot of metabolic acidosis, renal dysfunction, and there can be sepsis and all. So, but even it's usually not justified, especially in our case that we are discussing. We have seen excellent recovery and patient is on the recovering trend. So definitely retransplant is not an option for this at this moment of time. And we have seen even patient do recover within 2-3 months after transplant, even if they are small for size. This ascites disappears and the bilirubin comes down. So I would like to wait for such cases.
Yeah, but like I said, when you wait, I don't think we've ever retransplanted a small for size because it's just not possible.
I think of late a few algorithmic models have come up. Many people have, from even India, I think ILBS has produced a algorithm for predicting more high chances of mortality, which can be looked up as offering early transplant for such scenarios. But obviously they need validation and, for further.
Right. Okay, so just my last slide, the key takeaway messages from this case. Early graft dysfunction is not uncommon after liver transplant. Evaluation must be done for the cause according to the timeline of events on when the graft dysfunction is happening. Small for size graft or syndrome is diagnosed after excluding vascular, biliary, infective, and immunological causes. Recipient selection and portal flow modulation may help prevent a small for size graft. And preferably, you should use a graft with more than 0.8, and if it's less than 0.8, then the patient should probably be a low MELD score recipient. There is a definite role of portal inflow modulation. I think that's the only thing which is really proven with good data. General support, nutrition, prevention of sepsis form the mainstay of management. There is really no effect of prostaglandins or IVIGs or NACs in prevention or treatment. Plasmapheresis does help in some selected patients, and retransplant can be considered, but like I said, it's really difficult to retransplant these patients because most times they become septic and are not retransplantable. Thank you. Any questions or comments?
Congratulations, Neerav, for a wonderful case. My question to you, is there any role of tips in a small for size?
So, there's, I think I skipped that slide there, I showed one. So I think there's just one paper showing 1 or 2 cases of tips. So yes, theoretically maybe, but there's really no data to support it, and I don't think anyone does it.
Most of the time,
we've never done it.
It's
but yeah, people have tried it. I think few case reports, but no role.
Most of the patients will not have only ascites. They'll have a bad cholestatic liver.
Yeah,
and there'll be a lot of necrosis on the biopsy.
And with a bilirubin of 15,
it'll be very difficult to do anything like that. The only thing is somehow we need to pick this early on because it happens early. It manifests a little late. So we always think it's a second week phenomenon, but it's actually earlier.
But over a period of time, when it evolves, lot of patients develop refractory ascites. Even they are pouring over a period of 6 months, 1 year. So the main problem with small for size is recurrent ascites. That is the problem. Cholestatic liver is there,
but I think if it is happening more than 4 to 6 weeks or 3 months, it is something else. It could be sinusoidal.
I think once these people recover, they just recover.
Yeah, it could be sinusoidal obstruction syndrome or something like that. HVOT something, but otherwise it's very difficult to say that.
And even late, so if I'll just extend your question, even the late tips we have done after transplant, maybe 2 years, 3 years later, for recurrent ascites, we've had bad results.
We have done one in post DDLT, sinusoidal obstruction syndrome, just for ascites, waited for 6 months, it did not resolve, did couple of biopsies, whatever possible.
We've also done for sinusoidal obstruction, it doesn't work.
He got better transiently, but he came back with ascites. Thank you.
I have a question, a hypothetical question.
Questions are for the panelists, no?
I think you've questioned them enough. Anyway, it's okay, either of you. In an anticipated situation where you are like this guy was 120 kg, anticipating a small thing, is there any scope for doing a prophylactic splenic artery embolization pre-op?
So I think probably intra-op embolization or ligation, I have not heard of pre-op. But I'm not sure if anyone does it, or I have not.
The patient is already very sick, complicated patient, pre-operatively, he's a sick guy. So I would be, because there's very high risk, there's no, too much of a procedure. Much better is that intraoperatively surgeons are measuring pressure, and if it's high, then you do it.
No, but see, in splenic artery embolization, even in normal cirrhotic patients, you do them. There's high chances of infection and abscess. So
splenic infarcts and all.
Won't tolerate. I don't think they will tolerate a
splenic infarcts. You can have more decompensation.
And they'll probably become septic.
We say these patients who are going for transplant, please don't touch them. Do nothing. So that is, I think all of us follow that.
I have a comment. Excellent discussion. But I am thinking that for these patients, better prediction models to see who will, who is at what risk, and then have a better algorithm of how to intervene. I think we are done reasonably okay, but I think there is scope for improvement in the...
No, I totally agree, and that's why this recent ILTS conference was held. It was just purely on small for size. And it is because, see, the Western world doesn't see this. So this is our problem, actually.
So the message really is, we need to collect data so that we can build better algorithms.
Definitely.
Just for teasers, one thing is I think we might have to biopsy earlier to see this phenomenon. I don't know we will do it or not, but time zero biopsies, we used to do it sometime long ago when UK surgeons and everybody. Time zero biopsy used to show some shear stress, and around the zone 3, there used to be some necrosis. I don't know if it translates into this, but I'm just saying that. Do we get very late to do splenic artery embolizations and all that? Do we have to do something early, if not done intra-op? So that's what.
So just one question, sir, for Dr. Naveen, sir. Sir, in this patient, we already know this is a risk, at risk for small pore size syndrome. You told that we need to decrease immunosuppression in this patient. But on the day one, when there is bilirubin so high, AST is also elevated. So at that point, you were waiting for the reports to come. So we'll still decrease the immunosuppression. How can it take this?
Yes. Yes. I think sick patients hardly reject. So sarcopenic sick patients hardly reject. So this we have learned the hard way. We've lost patients to sepsis, and hardly if a patient has to reject the organ, you do whatever they will do it. Yes, you will do a lot of immunosuppression, but early on, if you have to save this patient from infection. If there's a little bit of rejection, you can still increase the tacrolimus little bit. We should not overstress with high-dose steroids and all that. We lose these patients otherwise.
Okay, I think we wrap it up. Yeah, thank you.
Thank you.
Thank
Great
you.
discussion.
Thank the panelists and Dr. Saraf for an excellent discussion.
I request the chairperson to please be seated because this session will continue. The next talk is on when to say no for liver transplantation in ALF, and the speaker for this talk is Dr. Y.K. Chawla. Dr. Y.K. Chawla is Senior Consultant Gastroenterologist and Hepatologist at KIMS Bhubaneswar.
Thank you very much, Subrat and Pankaj, for asking me to speak on when to say no to liver transplantation in acute liver failure. We know that acute liver failure is severe hepatic injury with altered coagulation and sensorium in the absence of pre-existing liver disease. While drug-induced liver injury is the commonest in the West, viral hepatitis is commoner globally, and so also in our country. Better intensive care, attention to fatal complications like cerebral edema and infections has increased transplant-free survival. And transplant-free survival is better with HEV, HAV, unfavorable with HBV, DILI, autoimmune, and indeterminate causes. So over the decades, the spontaneous survival has improved significantly. So also the survival after emergency transplantation. The intracranial hypertension has also decreased from 76% to 20% in the recent cases, and mortality because of cerebral hemorrhage, cerebral edema has also decreased. This spontaneous survival more often occurs in young than the elderly, and acute liver failure as a cause of transplantation is in most of the centers constitutes 8 to 10% worldwide, and so also in India it's between 5 and 7.5%. There is one dilemma whenever you are taking up these patients of ALF, that when you do a TJLB, one of the studies has shown that about 16% of these patients which were diagnosed as ALF initially turned out to be ACLF. But one needs to treat the etiology, hepatitis B, mushroom, you have antidotes, and paracetamol, which is not common here, could be treated. But whenever these patients come to us, consider all of these patients for transplantation. And they should be referred in a timely manner. This referral indicators are if the INR is more than 3 or if it is increasing, patient has grade 2 to 3 hepatic encephalopathy, has hypotension despite resuscitation of fluid, lactate levels of more than 3, AKI, bilirubin more than 15, and a shrinking liver volume and hypoglycemia. And we all know that critical care management in these patients is absolutely important. Try to do an early CRRT in case the patient has evidence of acute kidney injury. Cerebral edema needs to be managed very actively because it is the intractable cerebral failure or the brain death which is the biggest contraindication for doing a transplant in these patients. So the most important is saying no for liver transplantation is if the patient has evidence of cerebral failure. So normally the intracranial pressure is about less than 15 millimeters, but it becomes pathological when it becomes more than 20 millimeters mercury, and as the grade of encephalopathy increases, the chances of cerebral edema also increases. So we need to manage these patients. Intracranial pressure monitoring is invasive and usually not recommended, but whatever other methods are there, they are also not very ideal. The one which is most commonly used now is the optic nerve sheath diameter. And if the value is more than 5.7 millimeters, it has been shown to show some correlation with raised intracranial pressure. CT scan also may be done, and if it shows brain edema, is a definitive evidence of cerebral edema. Infection is another important cause which takes up these patients and could be one of the reasons for saying no to liver transplantation. As bacteremia occurs in about 80% of cases, you may even have fungemia in 5 to 32% of patients, but one has to be very careful not to give fresh frozen plasma to these patients because it would increase unless you're doing some intervention, it would increase the intracranial pressure. Take care of hypoglycemia and try to keep the sodium between 145 and 150. Nutrition should be started as early as possible, and N-acetylcysteine has been shown to be of benefit both in acetaminophen and non-acetaminophen. So it's a fairly difficult situation which patient should be taken up for transplant. So we have to keep these things in mind. Patient who's unlikely to survive without a liver transplantation should be taken up. Likely may not require a liver transplantation are the group of patients who are improving, but there is a group which is too sick for transplant. And for this, prognostic models have come up over the years. These prognostic models should be easy to use. they should have a high accuracy. That means a high positive predictive value and a high negative predictive value. Unnecessarily, transplants in acute liver failure have been shown to be done in about 20% of cases, and there is no ideal prognostic model for these patients. Most of the prognostic scores are retrospective, and very few of them are prospective. And each of these prognostic scores has its own advantages and disadvantages. But something which has come up recently, and Dr. Acharya is there with us, they have shown that dynamicity of the prognostic models has improved the identification of patients who are likely to survive or not likely to survive. But the only negative aspect of this is when you assess these patients after 48 or 72 hours, the chances of infections and cerebral edema may affect the survival. So, decision for taking up the patient for transplant is a composite decision taking all the factors into account. One of the earlier studies showed that a patient with a MELD of more than 30, 94% of these patients died without a transplant, and less than 30, 91% survived. Later on, studies say that 35 is a cutoff between survivors and non-survivors, but this value has been studied, and positive predictive value is 88%, negative is 73%. And the problem is with MELD is your INR estimation may not be very accurate because of the lab variations. Clichy is not important for our country because factor 5 is not estimated. There are other scores like the bile score, ALF-SG score from the US, our own from PGI, clinical prognostic indicator, and creatinine lactate score. All of them have their own advantages and disadvantages with different cutoffs. But I'll go into this dynamic model known as the ALFED model from All India Institute. Subrat Acharya was the main author, where they assessed the arterial ammonia over a period of 48 hours, bilirubin, hepatic encephalopathy, and INR. And they gave scores on these 4 parameters and suggested that the positive predictive value for a score of more than 3 was 74%. It increased to 93% when the score was more than 5. And negative predictive value also decreased with this. So although it may not be the ideal model for predicting, but it at least gives you that 93% of the patients need to have a transplant if they have a score of more than 5. The only negative is that you have a waiting time of 48 hours, and that delays selection. The famous King's College Hospital criteria has a value which is lesser than MELD, and they have lower positive predictive value and negative predictive value. People have taken up lactate into it and phosphates into it, and has not been shown to be of much benefit. Similarly, SOFA and Apache scores have also been studied and found to be of some use. Arterial ammonia, lactate, all these have been studied. But I'll take you to the study from ILBS, where 100 patients of acute liver failure, in the 4 criteria of King's College, ALFED, SOFA, and Apache, they found that they all differentiated well between survivors and no survivors, but found SOFA to be excellent with good sensitivity of 87% at 48 hours, and ALFED had a good specificity of 84%. So they suggested that dynamic scoring results in better prognostication, and SOFA and ALFED in combination may be the best. But what happens when you transplant these patients in acute liver failure? The results are slightly less because of the emergent conditions. It's about 10% lower in acute liver failure as compared to other conditions. And these patients post-transplant tend to have a higher incidence of infections. So the outcomes from different studies have shown that you may be missing out some patients on transplant and some may die while the waiting list is being done. LDLT in India, which is more common, results are almost same between LDLT and DDLT, and survival is about 79 to 80%, but should always be done in experienced centers. So what are the guidelines of EASL in 2017? The only contraindication that they mentioned is irretrievable brain injury. That means non-reactive pupils, no spontaneous ventilation, uncal herniation, loss of middle cerebral artery flow, etc. And relative contraindication is if the patient has evidence of sepsis or infection, which is there in about 20 to 30% of cases, and if they do not respond to antimicrobials, rising vasopressor requirement, uncontrolled ARDS, and low cardiac output are relative contraindications. Similarly, patients who do self-harm, mental illness, again are a relative contraindication. This study shows that poor outcomes depend on the recipient if the age is more than 50 years, has evidence of brainstem failure, sepsis, ABO incompatible, invasive fungal infections requiring increased inotropic requirements and creatinine more than 2 milligram, but also is dependent on donor if the age is more than 60 years, has evidence of steatosis because everything has to be done very fast, BMI more than 30 and decreased size grafts. So bridge to transplant, everyone is familiar that plasmapheresis does help in these patients. And my last slide shows that the recent INASL recommendations of saying when not to transplant is also important. If the patient is improving, criteria and eligibility has to be reviewed regularly. So there is a role for dynamic model. Any patient of acute liver failure with organ failure, especially circulatory and respiratory, should also be a relative contraindication. So also ongoing sepsis and invasive fungal infections. But certainly the absolute contraindication is brainstem death and absent reflexes. So thank you very much. We just have to carry home the message that anyone with brainstem failure is a strong contraindication and relative are the other organ failures which need to be corrected while the patient is hospitalized. I didn't mention about the comorbidities, but comorbidities also is an important component of choosing whether the patient has to be taken up for a transplant or not. Thank you very much.
Open for questions. No questions, no comments. Such a very good talk. Thank you very much.
Thank you.
Our next speaker is Dr. Vivek Vij. He will be speaking on donor evaluation for liver transplantation in genetic and metabolic diseases. He is presently director at AILBS Fortis Hospitals, Delhi NCR.
Thank you very much. Thank you, Professor Acharya and Pankaj, for this kind invitation. So, the task given to me today is to present on donor selection in LDLT for genetic and metabolic liver diseases. It's a kind of topic which is very different and difficult, but I'll try to just do justice about this. So liver transplant as such is a very much accepted treatment for several metabolic liver diseases, and survival seems to be excellent with 5-year survival touching around 85%. When the primary metabolic defect is hepatic in origin, liver transplant would replace the liver and will also treat the metabolic disease. But if it is outside the liver, then of course it will replace only the damaged liver and there will be chances of recurrence after transplantation. For conditions in which the primary metabolic defect is extrahepatic, as I told you, the recurrence might happen. So this paper appeared in 2010 for a series of pediatric liver transplants. pediatric liver transplants, and we can see that the most common reason for pediatric liver transplant all over the world is biliary atresia, followed by metabolic liver diseases, and in the metabolic liver diseases also the most common reason seems to be urea cycle disorders. So touching upon liver transplant in India, most of the cases are living donor liver transplant with about 20% DDLTs. Pediatric transplant itself is very less, forms about 5 to 10% of total transplant scenario, probably because funding is less and people come forward for transplant, don't come forward for transplant because of financial reasons. We have seen that in states where there is a funded program for pediatric liver transplant, the cases of pediatric transplants are much higher as compared to other states. So how do we select? This is a usual selection of donor for any disease. These criteria have to be met before we take in donor as a healthy donor for transplantation or donation. Donor age has to be between 18 and 60 years. Donor BMI has to be okay. There should not be any hypertension or controlled hypertension. There should not be any diabetes, cardiovascular, hematological status, and all other criteria have to be met before we check in the donor for donation process. So what is the specific thing? If we choose a donor for metabolic liver diseases, what are the special criteria, or where should we be very vigilant to select such donors? So reasonable steps must be taken to exclude genetic diseases. We know that genetic diseases travel in family, especially in countries where there is consanguinity. Parents might be affected, siblings might be affected, and these are the ones which are allowed in law to donate. So in every case of donation, we should suspect that donor is having some form of genetic metabolic diseases and try to rule it out before we embark on donation process. This is very important. Now, just to understand this topic, this is just a small classification. There are many disorders which are autosomal recessive, many are autosomal dominant, some are co-dominant, and some are X-linked. Now the genetic patterns of inheritance depends on these patterns of inheritance. Most common reason for transplant other than biliary atresia and urea cycle disorders is a Wilson's disease, which is a prototype of autosomal recessive disorders, along with hereditary hemochromatosis, PFIC, and urea cycle disorders, except ornithine transcarbamylase deficiency. Autosomal dominant disorders behave very differently, like Alagille syndrome. Autosomal co-dominants also behave differently, that is alpha-1 antitrypsin deficiency. And X-linked disorders like OTCDs also behave very differently. So this is a broad classification we should try and keep in mind before evaluating the donor. Now, basics of donor selection in a metabolic liver disease. Now, these inheritance patterns, which I have told you, dominant, recessive, co-dominant, or X-linked, are not classical. There are many mix-ups. There are cases of co-dominance, there are cases of compound heterozygosity, there are cases of variable penetrance and unknown factors. Even if the donor looks fine, healthy, liver function tests are normal, might be affected with the disease. So in every case, we should try and rule out the disease pattern in donors. Genetic testing seems to be the gold standard and desirable, but it's not widely available, and it is very time consuming. And in many circumstances, we don't know the primary etiology in recipient or child. We don't know the genetic pattern. Thirdly, clinical diagnosis is not always accurate in donors, like biochemical profile, challenge tests, liver biopsy, other surrogate markers like KF rings and Wilson's disease. These are not very accurate. Then patient sometimes is referred in a very critical situation where we don't have time to enter into the genetic mapping of the patient as well as donor. So all these criteria would define how would we go about selection of donor in such cases. Now coming on to our first group of autosomal recessive, which is exemplified by Wilson's disease, which is a disorder which we commonly see, and the presentation of Wilson's disease can happen in infancy, childhood, early adulthood or late adulthood, depending on the penetration or genetic pattern. In every donor of the Wilson's disease, we go ahead with clinical profile mapping of donors. We go for liver function test, we go for copper analysis, ceruloplasmin, KF rings, and in some cases, in my center, we have started doing liver biopsies for such cases also. The genetic profile, as told you, is a gold standard, but usually is not available or patients are very sick and it's very, time-taking process. But literature tells us that any heterozygote in Wilson's disease can be accepted as a donor for a recipient of Wilson's disease. So let's see, homozygotes or compound heterozygotes. Compound heterozygotes are also called as genetic compounds, which means on both the alleles, there are different, on both the foci, there are different alleles, and these are called as compound heterozygotes. And homozygotes, they should not be acceptable as donor. And this can be proven only with the genetic analysis. Now, when we talk about donor selection in Wilson's disease, especially we should look for ATP7B mutation in donors when we compare it to recipients. Now, for the reasons I told you that genetic analysis is not always available. So what is our protocol of Wilson's disease for selection of donors? So we go ahead with a liver function test, which should be normal, 24-hour urinary copper, and sometimes challenge test if it's borderline, serum ceruloplasmin levels, and slit lap analysis. If these are okay, then we are more or less okay with accepting the donor. Although some series have also stressed upon preoperative donor liver biopsy to rule out subtle signs of heterozygosity or compound heterozygosity. And in such cases, you can find early signs like mild steatosis, glycogenoted nuclei in hepatocytes, histological features of autoimmune hepatitis, fibrosis in late cases. So it depends on center to center, but if all the clinical criteria which I mentioned in the last slide are okay, probably there is no need of getting the liver biopsy done. So these papers highlight the long-term outcomes of heterozygotes. Once we prove clinically or by genetically that patient is a heterozygous, then the outcomes are fantastic. It does not affect long-term outcomes after the liver transplantation. So this study, there were 32 donors, 90% were from parents, which are obligatory carriers and probably heterozygotes, meaning a high probability of carrying the mutated gene and potentially some minor abnormalities in copper metabolism. So in heterozygotes also, we can have some abnormalities in copper metabolism as highlighted in the next slide. So abnormal donors, heterozygotes with abnormal metabolism might have higher serum copper, lower serum ceruloplasmin, and higher urinary copper. So these borderline changes can be seen in heterozygote donors too, but they don't affect the long-term outcome. So these are not clinically important or relevant variations. So again, this another study which highlights the same thing, that heterozygote donors, even if there are small changes in copper metabolism or decrease in ceruloplasmin, are okay to accept as donors. Now, hereditary hemochromatosis is another type of autosomal recessive disorder, and it is slightly different from Wilson's disease. Clinical diagnosis of hereditary hemochromatosis is very difficult. We go for liver biopsies also. So in case of lack of diagnosis, we would like to rule out the genetics of the donor as well. So in such scenarios, we like to go for genetic analysis of recipient as well as donor before accepting the donor as a viable donor. Another disease is PFIC, that is progressive familial intrahepatic cholestasis, which has 3 variants, and these 3 variants are very important. If a patient comes to you at an early stage, like infancy or childhood, then it's very difficult to differentiate between different types of PFICs. Once it is difficult to differentiate, genetic analysis would tell you which type of PFIC it is, and if it is PFIC, if genetic analysis matches with the donor, only then we should accept the donor as a heterozygote donor. We should not accept the donor if the patient presents early in the life. But if the patient presents late in the life, in the late adulthood, then chances of PFIC1 and PFIC2 are very less, very, very less. So it's most likely PFIC3, and we can accept the donor without doing genetic analysis. Autosomal dominant disorders like Alagille syndrome, again the importance of genetic analysis before accepting the donor is very important, because literature is replete with the case reports saying that Alagille syndrome after transplants leads to graft dysfunction, and also it can be transmitted. So in such cases, we have to have a proper donor biopsy before accepting the donor as a right candidate for donation process. Now, this is a paper for Alagille syndrome where they say that they did 2 cases, and both the cases were rejected during the surgery with intraoperative biopsies where they could find the paucity of bile ducts during the surgery. So we have to do preoperative biopsy in Alagille syndrome for the donors to rule out any disease process, any subtle disease process. Again, the same interpretation from another study, which also says that we have to do a preoperative biopsy, and in most of the cases genetic analysis also, to rule out the donor is not affected. Although it's an autosomal dominant disease, but as I told you, for the reasons initially I told you, that there are many other reasons why a donor is not manifesting the disease. So we have to find out the subtle nature of the disease and do a biopsy and genetic analysis before the surgery. Another disease is alpha-1 antitrypsin deficiency, which is an autosomal codominant disease. And again, in alpha-1 antitrypsin deficiency, we all know that there can be common mutations which are PIS and PIS mutations, and there can be, these mutations can occur together and they can manifest subtly in the donors. And we have to do biopsy and genetic analysis for these cases as well. So this series is for alpha-1 antitrypsin deficiency, which again says that proper preoperative evaluation with biopsy, LFTs, and genetic analysis is important, as alpha-1 antitrypsin deficiency can manifest if it is not diagnosed preoperatively in donors. It can manifest and can affect the organ function later on. X-linked recessive disorder behaves very differently, that is ornithine transcarbamylase deficiency. This leads to hyperammonemia, and it has been clearly stated that OTCD heterozygote carriers donors should be avoided in most of the circumstances if other donor is available. If the donor is not available, then we can evaluate these donors and accept them as donor. Otherwise, we should refuse accepting such donors because they would lead to hyperammonemia in recipients post-transplant and would affect the outcomes. So these are some studies of long-term outcomes after pediatric liver transplant, which is touching around 85%, as I alluded earlier. At our center, we have completed about 180 pediatric liver transplants out of 2,800, which is about 6.5%, mostly for biliary atrasias and some cases of PFIC and Alagille syndrome, with an in-hospital survival of 97% and no donor mortality, with 50% of donors being done laparoscopically. So take-home message is donors are who are biologically related to potential recipients with hereditary liver disease should be screened, and it should be kept in mind that they might be affected subtly in the liver before transplanting. When available, knowledge of genetic mutation is very important. Minimizing the risk in the living donor liver transplant requires consideration of hereditary liver disease in biologically related donors and recipient pairs. Identifying these disorders is beneficial to long-term outcomes of the donor as well as recipients. Thank you very much. Sir.
Thank you, Vivek. It's a very nice presentation, a very important topic in my opinion, because we in LDLT setup face this day in day out. No, in my practice, it's the adults which are more in my discussion point. Now we presented our this was when I was in Vedanta, the largest series of Wilson's disease living donor liver transplant. I think 18 patients were there. So I tell you why I'm telling this. When I sent this paper, it was really heavily discussed where did you get the donors from. So 2 out of these 18 were parents, 3 were siblings, and then there were a couple of cousins and all. They were all fine. And the reviewers were very, very clear. What did you do for parents? So we hadn't done liver biopsy in them actually. We just did serum ceruloplasmin. Also, this was initially we did not have clue as to what is the right thing and what is not right. So we did ceruloplasmin. We had done urinary copper and KF ring in all these patients. So maybe that if you have parents and all and you are taking a Wilson's case, you should probably do a liver biopsy. That's what I learned from that paper. It's published now. It's a very useful paper in my opinion because it made us learn a lot from that. Other point was about the pediatric, as you say, allegedly you said, which I see my colleagues using it. Now you did mention that you must have a biopsy in the donors, right? So would you do a biopsy if it's a non-related donor as well?
No. No.
It's only for parents.
If it's a non-related donor, then biopsy is not needed.
It's only for parents, right?
Only for parents, especially parents and siblings. Biopsy should be done.
Correct.
If there is some kinship.
Yeah.
And I agree with you for your first case that if it's a Wilson's disease and it's a related donor, we should embark on biopsy before transplantation.
Yeah. Because when we started initially about 2007-8 on the early patients, we really did not know what is right, what is wrong.
Yeah.
So it was quite.
We can find subtle changes in the
correct,
liver. Yes.
Correct.
Most of the genetic disorders that we see in India that require transplantation is Wilson's. We hardly see the others. In Wilson's, the only time when you need a transplant if they come with acute liver failure. We don't have time for genetic testing.
Yeah.
And we don't have time for very elaborate other tests also. So you have to make a quick decision,
Right, sir.
So
I think you're right. I mentioned in my slide also, if it's a clinical situation is not warranting, there is no time, then of course we can't go ahead with a genetic analysis which would take 3 to 4 weeks, first for recipient and then for the donor. So there is no time for that.
So I think KF ring, yes, we can see in most places, and ceruloplasmin we can see. And if there is no other gross liver disease, LFT is normal and everything else is normal, I think you just have to, if the family wants it, you just have to go ahead. I think we have little choice there.
Right. The same point what Dr. Koshi was mentioning. As you told, the parents, if they are healthy, they would be heterozygous if they have no manifest disease. And if there is a situation of ALF, liver biopsy won't make you any wiser. You need a genetic test.
No, actually, I agree.
Instead of going for siblings, if the parents are healthy and fit, in Wilson's, in acute liver failure, you can go accept parents as a donor. Even, doing a ceruloplasmin copper is all right, but in an emergent situation, I don't think that liver biopsy will add any much to
I will answer your question. So, for Wilson's disease, you are perfectly right, because the genetic pattern of inheritance is very well defined. But all over the world, evidence is accruing that there are certain inheritance I would say incongruences. It's not always autosomal recessive disorder. There can be certain kind of incomplete penetrance or codominance or there are other patterns.
Compound heterozygotes is a situation
compound heterozygotes. So we actually don't know. So that's why people recommend liver biopsy to be done before donation process. Otherwise, in practical experience, it is not needed. In most of the centers, we have found that we can do without biopsy also.
Just to mention Dr. Koshi's point, I think a very valid point, but I don't think that we had many patients of Wilson's who were not acute liver failure. They're actually, been going on for long. They presented to us after they have, sort of exhausted their therapy with penicillamine and dipenolol, and then they had come to us, So they were actually typically like, chronic liver disease patient who decompensated, diagnosed Wilson's was maybe 7
Actually,
8
we
years
see
back.
all kinds of pictures. Like we see ALFs, we see ACLFs, we see chronic liver diseases, depending on the treatment given before.
Yeah, the other situations are really should not occur. That is a sad thing, if somebody who was diagnosed 3 years ago with Wilson's disease comes with problems. Sometimes, yes, they may not take their medications, that's different. But today, the only situation really that may occur is with acute liver failure. The first time they present. Otherwise, they should never come to that situation. That is my point. Yes, I agree with you. They do come in that situation, but they should not. We should do everything possible to ensure that they don't come to that situation.
So Dr. Sohen is here. I would like to invite him on stage. Dr. A.S. Sohen, he is Chief Liver and SBP Surgeon, Medanta Hospital, Gurgaon. I would like to invite our chairpersons for the session. Dr. Gaurav Mahajan, Consultant Gastroenterologist, Command Hospital, Udhampur. Dr. Nimesh Tarve, Consultant Gastroenterologist, Military Hospital, Jaipur. Prakash Chand T, Consultant Gastroenterologist, Shriram Hospital, Jodhpur. And Dr. Ravi Daswani, Consultant Gastroenterologist, Midas Hospital, Nagpur. Chairpersons, please come on stage. Thank you. Our next talk will be recompensation in liver disease. Dr. Praveen Sharma is the speaker. Dr. Praveen Sharma, Professor Gastroenterology and Hepatology, Sri Gangaram Hospital, New Delhi. Thanks.
So, good afternoon. I will be talking about a topic which is slightly new, in terminology at least, is recompensation in liver disease, the definition, the frequency and the natural course. We all know in our clinical practice we have seen some patient, maybe of hepatitis B, of C or maybe alcohol. If we treat them, most of these patients, they recover well to the extent that probably they don't require much treatment. So this is a normal clinical finding by most of us. So this terminology is now structured as recompensation in liver disease. So let us see what is the natural course of cirrhosis. If we do not treat the etiology of the liver disease, there is an increasing liver fibrosis, increased portal pressure, that is more than 6 to 10, which will cause the label as chronic liver disease. Then from compensation to decompensation, if the etiology persists, there is an increase in the portal pressure, which is more than 10. We call it that clinical significant portal hypertension. This is a stage where patient start having ascites, development of varices, and if the etiology persists and we do not treat this type of patient, they become decompensated in the sense of they may have a variceal hemorrhage, they have ascites, encephalopathy. Jaundice is plus minus under decompensation, and they may have further infection, and we call them as further decompensated cirrhosis. So this is a natural course, and we consider as one way if we do not treat the primary basic pathology of the liver disease. But what happens if we have a successful treatment of the underlying etiology? Suppose if the patient has hepatitis B, we treat these patient has hepatitis C, or they are taking alcohol, patient stop taking alcohol. If there is a successful treatment of underlying etiology, we have seen that there is a reduction of functional and structural drivers of disease progression. Then sometimes these type of patients, they can have a U-turn, which we call as recompensation. There is a improvement in hepatic inflammation, fibrosis, and decrease in the portal hypertension. This will lead to improvement in hepatic function to the extent that many patients can be delisted if they are decompensated, many patients can be taken off medicines if they are normal. So many patients lost to follow-up because they remain all right and they do not come to the doctor for normal follow-up. So this can lead to sustained resolution of previous hepatic decompensation events. So this is nothing which is new, but the terminology has now come as a new event. Let us see some previous studies. I am focusing on one study on hepatitis C. These are the patients, about 502 patients of child B and child C were taken. They were treated with direct antiviral treatment. And if we follow these type of patients, at baseline, most of the patients were child B and C. And if you see by 12 weeks, there are about 20% of the patients who become, child A. When we follow this patient, they are 24%, and at 36 weeks, about 20% of the patient become from child B to or child C, they have reverted to child A. And they are delisted from the liver transplant. So what is seen, if we treat the underlying etiology, about 20% of the patient can be delisted and they revert to child A. Whether they remain, they have fibrosis, whether they were on beta blockers, so this is not known from this study. But there are certain percentage of the patient who can be reverted to child A status if we treat the underlying etiology. This is a second study which has shown that a notable proportion of liver transplant candidates with alcohol-related cirrhosis can be delisted because of clinical improvement if they abstain totally from the alcohol. This is again a big number, 1001. About 420 were alcoholic, about 403 was SCV. And we see the cholestatic is 101, cryptogenic or NASH rated is 70. If we see the chart, about 8% of the alcoholic, if they abstain from alcohol, they can be delisted from the liver transplant. About 7% after successful treatment of hepatitis C can be delisted, but only 1% of NASH-related or cholestatic, in which we do not have a complete or maybe a good treatment chart, can be delisted from the liver transplant. So these patients, about 8 to 7% can be delisted, and we say that probably they have recompensated from the cirrhosis. This is the latest study from 2022, and these are the patients who are hepatitis B and are successfully treated. All these patients have decompensated liver disease, about 320. They were all treated with entecavir. About 120 weeks treatment was given and they were followed up. Once the baseline DNA was quite high, about 6 logs, Child-Pugh score was 8, MELD score was about 14. They were given treatment, and let us see at 120 weeks of treatment, about 283 of the patient, about 60% of the patient, they are now compensated. That is, from the decompensation, they have converted to compensated. And we follow them for about 120 weeks. About 56% of the patient, they have, their MELD score become less than 10. Their CTP score become less, is child A. So about significant portion of the patient of hepatitis B, if you give them good treatment, can be delisted from the transplant and they can revert it back to child A. So these are the various studies which have used many criteria for maybe delisting or for maybe compensation. So we do not have an exact idea how much percentage of the patient, if you treat them, can be converted back to the normal stage in the sense that they can be delisted from the liver transplant. This is the studies, various studies. I have just make them in a table form. Numbers are quite high, 935 patients who were, it is a retrospective study, who were taken up, listed for liver transplant. And if you see the criteria of delisting is that there is no ascites, no hepatic hydrothorax, no peripheral edema, no HE despite treatment discontinuation. About 16% of the alcoholic can be delisted. And if you see for hepatitis C, about 5%, and total recompensation was about 8%, but the criteria taken was no ascites, no hepatic thorax. Whether they were on diuretics or not, nobody knows. Similarly, the other studies, about 70% of decompensated who were treated with entecavir, about 67% of hepatitis B can be, taken back to their child A status. This is a large study, about 84,000 patients who were listed for liver transplant. And we can see about, if you divide them into alcoholic versus non-alcoholic, about 2% of alcoholic patients can be delisted if they abstain from the alcohol for a period of time. And non-alcoholic is about 1.6%. We do not have the various cutoff, but about 2% can be delisted. So from all those studies which have taken a large number of patients, we can see that in alcoholic patient about 6 to 10% or maybe 15% can be delisted if they abstain from the alcohol. Similarly for hepatitis B, the chunk portion is quite high, it is about 50 to 60%. Similarly for hepatitis C, it is about 6 to 7%. So this is on an average how many patients can be delisted from the liver transplant, but whether this is recompensation or just a delisting from the liver transplant list, there is a controversy, what we call as recompensation, what we call as delisting. So we do not have a uniform criteria. So thinking on that, the Bivano 7 has come up in 2021 with some criteria which are not perfect in itself, that it is what is called as liver recompensation. When we say liver recompensation, it means sustained cure of the underlying etiology, suppression or removal of underlying etiology of the cirrhosis should be the first criteria, which we call as recompensation. Second is patient should have resolution of ascites and hepatic encephalopathy after discontinuation of diuretics and prophylactic therapies for HE. It means that patient should be off diuretics and patient should be off rifaximin and lactulose for a period of at least 1 year, and there should be no bleeding even if patient is on beta blocker. Third is sustained improvement of biochemical liver function, which is assessed by albumin, bilirubin and INR. So this is a definition which is given by Bivano 2021, and all three should be met to label as recompensation in liver disease. But I think there is a lot of drawbacks in that definition also. I just enumerate that. What are the limitations of current criteria? When we say sustained cure, suppression and removal, what about patients who have MAFLD or maybe autoimmune, overlap, PBC, PSC, because we do not have a definite cure of this type of patients. So probably these patients can never be recompensated because according to definition, but this is not so. Second is resolution of ascites, HE after discontinuation of diuretics. But we all know in our clinical practice, everybody has his own criteria to stop the diuretics. Sometimes we write down maybe take diuretics once in a week, sometimes we write down twice in a week. So there are different criteria. So we do not have a uniformity when to stop diuretics. So this has not been given in the criteria. The third one is the sustained improvement in biochemical liver function assessed by albumin, bilirubin and INR. But what does it mean, sustained improvement? What is the cutoff of that? I say bilirubin less than 1, bilirubin is less than 3. How much is the bilirubin? How much is the INR? How much is the albumin? This had not been given in the Bivano 7 criteria. And what about the CTP or MELD? What CTP score is considered as recompensation? What MELD score should be considered recompensation? So this has not been given. So this recompensation definition itself has got its loopholes. So now the second is, what are the factors which leads to recompensation in liver disease? So various studies which have taken their own criteria of recompensation. The factors which are listed in most of the studies that patient should have low MELD, high albumin, gender is female, high platelet count. In second study by Post et al. In 2021, 1001 patient the recompensation event was about 8 to 10%. They have come up with the almost same factor, that is the female sex, lower height, lower MELD, high platelet count, lower BMI, high albumin. So these are if you see all the four, female gender, younger age, lower BMI, and probably low MELD is considered as the factors which probably have impact on recompensation in liver disease. But what does all this mean? Female sex, low MELD, high platelet count, BMI low. But does it mean anything? So let us see another study which has taken a child MELD purgatory test. That is, MELD purgatory means the patient has got delisted from the liver transplant, means the MELD is less than 15, but still patient is not totally recompensated. So these factors shows female sex, MELD is more than 19, ALT is 60. So in everything there are certain things which are common. Let us see what are the factors which have lead to recompensation. If we see, the factors are listed on this side, and what we can conclude from these factors is on the right side. So etiological cure is the important thing which we know, that patient has to be treated because of hepatitis C, B or maybe for alcohol. Low MELD, female gender, low BMI. What does it mean? It probably means that there are certain probably superimposed genetic factors which also have impact on recompensation. When we say low BMI and no diabetes, it means probably non-NASH related are the things which probably leads to recompensation. When we say high platelet count, high albumin, probably what it means is that because HVPG and other things were not measured, so it probably indicates that these patients have low HVPG and portal pressure. So if patient is a female, patient has high albumin, high platelet count, it means MELD is low, pressure is low. So these are the probably patients who can recompensate from the decompensated cirrhosis. But there are other factors which are not evaluated, which includes HVPG, systemic inflammation, gut dysbiosis, which all have effect on liver recompensation. These factors has not been looked into any studies, so probably I think these factors should be looked into. What are the factors which leads to recompensation? So what is follow-up of this type of patients? There is no definite follow-up, but if we take about the first study in which 937 patients, out of which 8% have recompensated, they have decompensated in the sense that 4 patients, they become decompensated because they developed SCC. Another study which has shown that if they start taking alcohol, they start taking, because they had stopped taking hepatitis B treatment, these are the patients who probably got into decompensation events. So most of the time the decompensation remains because of the etiology again comes up, either because of B or because of alcohol, and in which the patient developed SCC. Maximum follow-up was seen is about 120 weeks of hepatitis B, and about 60% remains the same. So if the patient becomes recompensated, all the liver-related mortalities and complications reduces. This we know by studying hepatitis C patients. But the risk of SCC always remains. So these type of patients should be regularly followed up as the other patients of cirrhosis. So just to summarize, when we see a patient with decompensated liver disease and becomes liver hepatic recompensation, then patient should match at least etiological cure, resolution of ascites and HE, no bleeding for the last 12 months, even on beta blockers, and there is improvement in liver function. There are potential factors which can affect these, maybe the genetic factor, that is the female gender, maybe the low BMI, decrease in the portal pressure, but these are the patients who are at still risk of SCC and again decompensation because of the covering of the etiological factor. So these patients should be always followed up. So just to summarize, recompensation of decompensated cirrhosis is an emerging real concept which need better clarity of definition with respect to etiology treatment and improved liver function test. Recompensation frequency varies from 2 to 60% depending upon which criteria you are taking in various studies. Factors related to recompensation and its natural history after recompensation needs more studies, and these patients should be monitored as few subsets may decompensate again and may develop at risk of SCC. Thank you.
House is open for discussion. Any questions?
Sir, can I ask a question? Yeah.
Sir, please.
Sir, any role of transient elastography in assessment of recompensation?
There are various studies which have shown that if you treat patient of hepatitis C or maybe alcohol, if they abstain from the alcohol or hepatitis B, their transient elastography reduces over a passage of time. But transient elastography and HPPG has not been considered in the definition of recompensation. Still feel that probably it reflects that the patient is improving according to what we see in various studies.
Excellent talk, Praveen. So these recompensated patients, are they more of ACLF patients who have actually improved rather than decompensated cirrhosis which has reversed? Because recompensation does not mean absence of cirrhosis, the correction of cirrhosis.
I totally agree, sir. These certain patients, but most of the studies I have shown you that patients who have hepatitis B and they have decompensated, they are not ACLF patients. If you just give antiviral, most of these patients, they have reduction in the ascites, they have no varicose bleeding. So these are the real patients who have recompensated. Similarly for hepatitis C, they are not ACLF patients. So they have also recompensated. Maybe we can say that patients who are alcoholic and they have a superposed alcoholic hepatitis, they may recompensate because they have stopped alcohol. But as far as etiology is concerned, etiology has to be taken into care. So that is okay. In real ACLF, maybe if the patient has viral hepatitis along with alcohol, so these are the patients, they may recompensate, but this factor has not been taken care of in the Bivano 7 guidelines of ACLF criteria.
Professor Acharya.
Brilliant talk, but I have just to make one comment. You see, clinical hepatology is based on observations. Now, when you defined acute liver failure, it is a clinical definition, and depending upon the etiology and natural course, the acute liver failure are 49 definitions. But yet it is an established entity. When you defined acute and chronic liver failure, it is a clinical recognition of those cirrhotic who decompensate and die quickly in the hospital. You have given different definition depending upon what you see. But they exist, and the clinical definition differs. Similarly, recompensation is a distinct clinical observation in your clinical practice. There is a subset of group of patients who do excellently, right? And you follow them up. The only questions or gap which lies is defining their natural course well. Because if you see recompensation, you are making them equivalent to, say, compensated advanced chronic liver disease or compensated cirrhosis. They are usually cirrhosis. Decompensation in terms of cirrhosis, that is liver failure. What is ascites or a varicose bleed or encephalopathy? They are features of organ failure, liver failure. So if the recompensation patients, 10-year survival is about 85% like a child's A cirrhosis with A5, then you will probably establish, well, recompensation is a definite term, and a prognostication is a very important in clinical practice. So I think it's an important definition. I think it is an important concept, and it gives you a lot of leverage to study this natural course of these patients who are getting cured and identify factor much more details. So I think we should not ignore this.
No, I totally agree, sir. Whether patient who have recompensated cirrhotic, whether they are equivalent to patient who are compensated cirrhosis, this is still not known. Because compensated cirrhosis, they never go into decompensation as far as if you differentiate between these two. And the important thing is the natural history. Natural history is known till maximum of 120 weeks or maybe 2 years or 3 years, not more than that. So once we know the natural history of compensated cirrhosis is equivalent to the recompensated cirrhotic patient, I think we can definitely label that the recompensation is a definite identity. So natural history is important, sir. I totally agree.
Thank you for the lucid talk, sir. We are running short of time.
Thank you, sir. For our next talk, I would like to invite Dr. A.S. Soin, Chairman, Liver Transplant, Medanta Hospital, Gurgaon. And the talk is on curative therapy in HCC with portal vein thrombosis.
Thank you very much, and thanks to the organizers for inviting me to talk about something that I'm called all over to talk about. Initially started as a big controversy. So there are some increasing number of proponents who believe that some of the patients with portal vein tumor thrombosis can be cured. So let me take you through what I think. So just to get the definitions right so that you and I are thinking of the same thing, VP4 is the tumor thrombosis of the main portal vein, VP3 is the lobar portal vein, and VP2 and 1 are second order and distal to the second order. That's what we are talking about. And we all realize that in the updated BCLC classification, if you look at the advanced stage C, they have lumped together HCC with portal vein invasion with or without systemic spread in the same category C, and therefore they have been advised systemic treatment. But at INSL, we did better. We actually separated this group into C1 and C2. And C1 is the group that has portal vein invasion, and C2 is the one with extrahepatic spread. We're not going to talk about extrahepatic spread. We're just going to talk about what we can do for patients with HCC and who have good liver function, who have portal vein tumor invasion, but no systemic spread. As you can see, we can take some of them to transplantation. Some others will have ablative therapy. And if you look at this, what can we do for patients with HCC and PVTT? If they have bad liver function, they will obviously have symptomatic treatment. If they have decent liver function, but they have VP4 tumor thrombosis, then they will be initially taken up for systemic therapy, because patients with VP4 generally don't do very well with ablative or resectional or transplant options initially. But if the tumor biology proves not so deadly, then they will be taken through, selected cases can actually have ablative treatment even leading up to transplantation. On the other hand, if you have VP1 to 3, then selected patients can be taken up for resection or ablative treatment, and some of them will eventually become suitable for transplantation. So that's the overall high-level view. So let's talk about, I'm going to mainly devote this talk to liver transplantation, touch upon ablative treatment and resection for these patients. Now, how do we think that some of the patients with HCC-PVTT can actually have curative treatment and transplantation? So we recently published this, and basically we believe there are four kinds of logic to this concept that you can actually downstage some of the PVTT and take them through transplant. One is that PVTT should be actually considered to be loco-regional rather than systemic spread unless proven otherwise, rather than the other way around, right? And then we have known for a long time, for the last 15 years, that radiotherapy of various types can actually cause the tumor in these PVTTs to regress completely or partially. Then we have shown at our own center in a study that is published, and since then we have actually accrued many more patients, that long-term survival is actually achievable in HCC-PVTT after downstaging radiotherapy, followed by liver transplantation. And if you are among the increasing population of transplant physicians who believe that transplant benefit is important, both in the HCC and the non-HCC situations, then there is a clear transplant benefit of transplanting these patients compared to the next best option. Now, let's look at whether PVTT definitely implies systemic spread. No, it does not. There was this study from Korea which showed that in 27 patients with segmental PVTT, that's VP1 and 2, there was no downstaging, and they achieved overall survival of 63% at 5 years. They obviously did not give any downstaging treatment here. This is a retrospective, super selected group of patients, not sure what their selection criteria were, but they did not downstage them, which basically shows that there's a bunch of patients who, despite not having been downstage but having PVTT, they were cured with transplantation. So obviously, this PVTT did not spread systemically at the time. Similarly, another study from Zheng's group in China, they had 75 patients where there was HCC PVTT, there was no downstaging. And as you can see, guys with VP2 and 3 had between 50 and 60%, 3 to 4 years survival. So again, which says that many of these patients actually haven't spread systemically when they have PVTT. Now, radiotherapy improves survival and causes CR or PR, that's complete or partial response in these patients. We've known, I wouldn't dwell on that for a long time, but we have known for a while that this happens. A couple of studies, 41 patients, SPRT in PVTT and IVCTT, 31% complete and 39% partial response, and 120 patients, SPRT for tumor thrombosis of IVC and portal vein, again, 33 to 49% complete and partial response. So we know that can happen. Long-term survival in PVTT possible. I will quote two studies, AMC Seoul, that's the Asan Medical Center group, which basically showed that they were able to achieve a 1 year and 3 year overall survival of 87 and 60% among 17 patients with HCC PVTT who were downstaged with TACE and radiotherapy and then given transplantation. We published this 3 years ago, where we showed that with this protocol, where patients are Child's A or B, HCC PVTT with bilirubin of less than 3, where at least 70% of the liver is non-involved with tumor. They have detailed evaluation, including PET, CE, CT. If they have no extrahepatic spread and no lymph nodal spread, which we frequently check with US FNA, then they are given SPRT plus TARE usually. And what we have done is we've done both. We've done sandwich therapy with TARE-1, which is basically a mass scan to see where the yttrium-90 will go, and then TARE-2, which is the actual administration of the yttrium-90 into the tumor, and then follow it up with SPRT or TARE-1, SPRT, and then TARE-2 sandwich therapy. So anyway, after both these things are done, we wait for 6, 8, 10 weeks, even 12 weeks, even longer, and proceed if there is no longer FDG18 uptake in the portal vein thrombus, and if there is no contrast enhancement. And both these factors have to be there. And of course, we also look at ancillary things like reduction in tumor markers, PIVKA2 and AFP. And if there is seemingly like a partial response, we would, after 8 weeks, repeat an SPRT if necessary. And then eventually go to living donor liver transplantation. These are the various modes of downstaging, usually SPRT and TARE. So this is the update until 2020 with 3 years follow-up. This is adding on what we published. Total number of patients, 57 who underwent LDLT among patients with HCC and PVTT. 36 of them were downstaged and 21 of them were not downstaged. And these 21 were the initial patients. But in the last 5 years, we've always downstaged everyone. And this is the distribution of what they had, downstaging modality. The average time to downstaging was about 3 months. And this is what we had in terms of survival. And we now have 15 long-term survivors. That is more than 3 years, 6 of whom are more than 5 years. So in terms of the prognostic factors, if they had pre-downstaging alpha-fetoprotein, which was lower than 1500 nanograms per mil, they did better. And those patients with BP3 and 4, if they had PET positive tumors, that was worse than if they had PET negative tumors. That's what we found. So basically, they had an overall survival at 5 years of 57%. I've already told you that. And there's another, and Zheng has again published his paper on a similar protocol, which says that AFP less than 1,000, tumor less than 8 centimeter, and FDG avidity SUV less than 5, and BP 1 to 3 are good prognostic factors. If you compare what we did with what's available, you hardly get any median survival longer than 16, 18 months. So obviously there is clear transplant benefit. I will just show you the transplant benefit. So at 36 months, the transplant benefit with our protocol works out to be 23, and at 60 months, 33 months compared to the next best treatment. So now what about ablation of these patients as a definitive or a palliative procedure? Well, if you do TARE in advanced stage HCC, they obviously have a better survival compared to if they did not, or if they had systemic treatment. And it's not influenced if there is a single portal vein branch occlusion with tumor thrombus. But if both branches are occluded, then they obviously have slightly worse survival than if they did not have portal vein occlusion. Now, this is another paper which shows that ablative treatment with TARE, as opposed to conventional treatment, ablative is obviously higher dose. These guys have a huge improvement in overall survival from 18 months to 45 months compared to conventional TARE, and 4-year survival is about 53%. And this is a comparison of TARE versus TKI, and obviously it's pretty clear that the overall survival with TARE is far better, although recurrence-free survival was similar. This is a retrospective study comparing 100 patients of TARE with 77 of TACE, and again, radioembolization has better survival. And a word about resection. The large study from the Japanese multi-center data where they did about 2,000 odd resections for patients with HCC PVTT, and their survival was median survival was 2.87 years compared to 1.1 years who had alternative treatment. So obviously resection helped in these patients, but as you can see, less than half of the patients were actually, or less than a third of the patients were actually suitable for resection. Another study which showed that Child's A patients, BP1 to BP3, people who do not have distant Mets will benefit from hepatectomy with or without thrombectomy. And even if they have EP4, with vascular reconstruction of the portal vein with or without thrombectomy, these guys have better overall survival than alternative treatment. So, summary. PVTT does not necessarily mean systemic spread. SIRT and SPRT can result in partial or complete response in PVTT, we all know that. And selected patients with no extrahepatic spread will benefit from downstaging with TARE, SPRT, followed by living donor liver transplantation after 3 to 4 months with good outcomes. And VP1 to 3, no FDG avidity, low pre-downstaging alpha-fetoprotein and less than 8 centimeter, do better. And there is clear transplant benefit of this policy over non-transplant treatments. TARE is usually better than TACE in INASL, BCLC, C1 patients who do not have systemic spread in improving survival over non-ablative treatments and non-transplant treatments. Resection with or without thrombectomy or portal vein reconstruction can be done for selected patients with Child's A or occasionally Child's B with HCC PVTT. Thank you. Yes, sir.
Wonderful talk as usual. But you have also shown certain tumor characteristic and tumor biology to be important before you decide whether the patient to be transplanted or not. Now, have you done a prospective, these are retrospective analysis, because as a patient has come, you have tried to downstage them, you have to try to give them TARE or SBRT or a combination of them. And then when you found portal vein is free, you give a new liver. From this study, can you identify predictive markers in patients with particularly BP1 and BP2, BP3? BP4 is a different ballgame, they should be separated, right? To identify the possibility of giving them a definitive cure, that is new liver. Because you have done so much of data that is with you.
So, I mean, that's a very good question. There are two problems with that. It's not easy to do prospective studies on these patients, so we haven't done one. Most surgeons are not famous. No, I'm saying most surgeons are not famous for doing prospective studies. Yeah, so we have prognostic factors based on retrospective analysis. I already talked about those. Smaller tumor size, VP1 and 2, FDG avidity negative or low SUV, and response to first SPRT, that's something we've seen. Lower AFP starting levels like less than 1500. In our published study, we actually found that the delta of AFP being more than 2000 is a good prognostic factor. So these are obvious things because everybody realizes if you have low tumor markers and if you have no avidity on PET, it's going to be a good thing. So I think we currently have to stick to these. We don't have anything more exact.
Nice presentation, sir. Two small questions. So one was you showed overall survival, which was good, I think 60% almost 5 years. But what about tumor-free survival? I think that is important. How many recurred?
Yeah, so we had recurrences in 3 groups. Patients who basically had within UCSF who were FDG negative and who had low AFPs. Those were the 3 risk factors. So people who had 1 or 0 risk factor had a recurrence of less than 15%. People who had 2 had a recurrence of around 25%. And people who had all 3 risk factors recurred at 46%.
46, right. And second question, you have huge data on HCC transplanted. So have we gone back and looked at incidentally detected VP1 in the explant liver and what happened to those patients? So incidentally detected.
The honest answer is we have not.
Yeah.
But that's an interesting question.
Excellent talk, Dr. Swain, and I'm happy that you started using the in-ASL staging system. So, and you are part of it.
Part of the group, so yes.
So I have just one comment, which is, you have already showed it and presented it, that after downstaging, we need to wait for 3 months. That is most essential to understand the tumor biology. That comment is for the benefit of residents, that instead of immediately transplanting after downstaging, the waiting period is most important. And those who recur in that waiting period, they definitely do not merit transplant and would require further treatment, as you have done that.
So, I know what you're saying, that waiting period itself is a test of tumor biology.
Yeah.
So there are many tests of tumor biology. One of them is waiting period. In the living donor liver transplant situation, it's not always possible to wait a long time. So if the guy has responded in 6 weeks, he would be transplanted in the subsequent 6 weeks, maybe not the next day. So limited amount of waiting period is possible. But yeah, you can tailor it to individual cases. So suppose you have somebody starting out with a high AFP and they've needed 2 SBRTs to respond, I would certainly wait 3 more months after downstaging. Yeah.
Thank you.
Thank you, sir, for the interesting talk. We can have more discussion during the tea break.
If you don't mind, one question.
Please.
Swain, sir. Sir. Ajay from Vedanta Lucknow, sir. Sir, nice to see you here. One thing is that when we are talking about PVTT, we are talking that complete vein is blocked. But as you said, the anatomy is there. There could be some partial block or it could be some segmental block. So should there is any need to further go deep into it, that which segment is blocked? Is there any future in this direction?
I didn't understand your question. If it's a segmental block, then what?
That's what I want to say. In other cancers, we are not much into, if we see a vessel is involved, we straight away say the tumor is metastasized. But in liver, it is different because portal vein is part of the liver parenchyma in a way. So when we are talking of, we are not sure whether the tumor has spread or not. Is a segmental spread will be able to help us in this way? That is my question.
So I think that generally it's true that everybody believes that the more distal the tumor thrombosis, the less likely it is to be systemic. But it's not a one-to-one relationship. And the other thing is that we already know that in renal cell carcinoma, it works pretty well to actually thrombectomize the IVC and the renal vein thrombus with the resection, and there is a survival advantage to that. And even there, the thrombosis doesn't mean systemic spread. So the same is probably true for portal vein in HCC.
Thank you, sir.
Our next talk is a case discussion on HRS, AKI. And for that, I would like to invite our speaker, Dr. Kaushal Madan, Director, Hepatology, M.I.C.E, New Delhi. I would like to invite panelists for the talk, Dr. Piyush Kumar, Consultant Gastroenterologist, Fortis, Okhla, New Delhi. Dr. Dharmender Kumar, Consultant Gastroenterologist, Base Hospital, Delhi Cant, New Delhi. Dr. Piyush Ranjan, Professor Gastroenterology and Hepatology, Sir Gangaram Hospital, New Delhi. Chairpersons, please be seated. So panelists will be there. And Dr. Rakhi Maiwal, Professor Hepatology, ILBS Hospital, New Delhi.
Good afternoon, everyone, and thanks to Professor Acharya, Colonel Puri for inviting me to this wonderful meeting. So, AKI in cirrhosis, and we have a fantastic panel of experts who will be talking to you in detail about all the issues which I raise, and if you have any questions, you can ask them and they'll be happy to answer. So, this is a case which was given to me by the treating unit by Dr. Puri. A 59-year-old male, chronic liver disease, child C, index presentation 2 years ago in the form of ascites, currently on spironolactone and salt restriction, now presented with 4-5 days history of fever, abdominal pain, decreased urine output for last 3-4 days. These were the labs hemoglobin 10.7, TLC mildly elevated, creatinine of 1.9, low sodium, albumin of 3.4, urine routine microscopy was normal, ascitic fluid analysis raised TLC 80% polymorphs, and this was a baseline creatinine done 2 months ago, which was 0.67. Currently it is 1.93. So this is a question to the audience. You can shout out. There are no voting pads. What label would you give this patient? Experts will tell you after this. So is it AKI? It is HRS AKI. It is HRS non-AKI or HRS type 1. So what label would you give this patient? So how many for AKI? How many for HRS AKI? So I think 50%. HRS non-AKI, almost none, 1. All right. So Dr. Rakhi, at this stage, what label would you give this patient and why?
Yeah, we're dealing with the AKI, which is possibly stage 3, and it's a severe form of AKI. So when you talk about HRS AKI, you should have done an initial volume assessment and expansion with albumin before you label your patient with HRS AKI. And the other thing which is very nicely told over here is the urine analysis. So we're not dealing with ATN over here, even though there is history of diuretic, sepsis and SBP, and a patient who's child C, very commonly, many a times with decreased urine output, you may also be dealing with ATN. So there, HRS, pre-renal, volume, non-responsive is something which is HRS AKI. So we're dealing with the AKI stage 3 over here.
Right. I think you made a very important point. Although the creatinine is 1.93, but you said it was stage 2. So for the benefit of the audience, would you like to explain that?
Yeah. So
why stage 2?
Because the patient over here, if you see the baseline serum creatinine, and therefore the staging has to be done based on the fold elevation from the creatinine. So if you see here, the patient is almost having a 300-fold elevation.
Yeah, so almost 2 to 3 times. So that's why I think stage 2 or stage 3, right? So I think another question which we keep getting confused because we keep getting newer definitions about HRS. So I think how would you explain the current definition in this patient? I mean, how the definition of HRS evolved over time?
Yeah, so I feel the definitions of HRS has been rapidly evolving, and now this year we just had a consensus again where we are changing all this, the shock. It's not necessarily that the creatinine definition we know, creatinine does not give us the estimation of the renal function. So therefore urine output, which was initially considered to be non-reliable, but especially when you're dealing with the critically ill patients or ACLFs or patients with severe AKI, there it is important that we catheterize and see the urine output and measure the urine output, and therefore urine output is now incorporated already. We've removed the serum creatinine, and again that 2 days waiting period is not necessarily required. What is required is a volume assessment and a good volume expansion, which should be done at least 6 hourly or 8 hourly, and you should see that you reach your targets of volume expansion, especially when you're dealing with stage 2 or 3 AKI, and not wait for those 48 hours. The other important thing is that it may not necessary that the patient may be having, so again, if you see especially ACLF patients and milder degrees of shock requiring some low dose of norepinephrine, you may still have HRS AKI, so shock is not an exclusion criteria, and again, a lot of data has emerged suggesting albuminuria, some degree of proteinuria also can be there as a measure of tubular dysfunction. So again, this microscopy and whatever findings are there, and now we are also trying to incorporate biomarkers. So all these definitions, this definition needs to be, a lot of caveats are there even in this definition.
Right, so I think the most important point is that from the original definition of serum creatinine more than 1.5, we have moved to the creatinine criteria given by the KDIGO classification, that is rise in serum creatinine of more than equal to 0.3 or rise in creatinine more than 1.5 times. And now we have also added the urine output criteria from KDIGO, but like Dr. Rakhi said, only in patients who are catheterized. So this criteria can only be used in those patients, not patients who come from home and tell you that urine output has gone down. It's impossible to measure in 6 hours how much urine they have passed. So, I mean, how do these new classifications align in the form of, we are talking about HRS AKI, HRS non-AKI. What is the alignment of these new criteria to make these kind of definitions? Dr. Rakhi.
The other important thing is when we say AKI, then the time duration is also important. Apart from the elevation in serum creatinine, and many a times we all see that the baseline value of serum creatinine may or may not be available. So what we are actually seeing in most of our practice in the outpatient setting and even in inpatient setting is AKD. So the AKI has been there for a longer period of time. You do not have. So this is how these definitions are evolving. And AKD is something which we are seeing more often. Most of these patients are already having AKD, which particularly in refractory ascites is very common. And again, CKD. So GFR assessment. We are not looking at GFRs, but it is very important. Even in a patient of cirrhosis who has ascites which is severe, if you check the GFR using the MDRD6 equation, many a times the GFR may be in the stage 3 criteria, means less than 60. So albumin is low and these patients may have high blood urea nitrogen. So GFR assessment is important, and based on the GFR assessment also, you may substratify your patient whether the patient is having a normal baseline kidney function or he's having a renal dysfunction on a background disease state of the kidneys.
Right. Dr. Piyush, you wanted to make a point?
No, I just wanted to ask Dr. Rakhi one question, that for current AKI definition, for current HRS definition, you need both. You need either. You need only the creatinine criteria or also the urine output criteria. That is number one. And number two, with HRS AKD, does it progress, evolve from HRS AKI, or what we used to call diuretic intolerant ascites or diuretic refractory ascites, that is HRS AKD? And what is the time frame? It's less than 3 months. So between HRS AKI and HRS NAKI AKD, what is the time frame?
Very relevant question. So for the first question, sir, like what you said is creatinine or urine output. So it's not necessarily that both are there. But yes, what we see is if both the creatinine is elevated and the urine output is low, you're dealing with a very, very severe AKI. In a normal creatinine also, urine output may be relevant. For AKD, it is the time duration. So it should not fall into AKI and it should not fall into CKD. There has to be a reduction in the GFR by 35% or an elevation of serum creatinine. And if it is the persistent reduction is less than 3 months, then it qualifies as AKD.
So to make it easier for the audience, I think if you just remember that acute presentation is AKI, subacute presentation is AKD, and chronic presentation is CKD, and chronic presentation is more than 3 months. So less than 3 months AKD, more than 3 months CKD, 7 days AKI. So just remember these, and if you want to still fit them in and want to know what they were called earlier, so the first one is called type 1 HRS, used to be called, and HRS NAKI is the one which used to be called HRS type 2 or slow rise or worsening of creatinine. And yeah, definitely, sir.
I'm a bit worried. You see, in real life, how does accept volume expansion, accept treating infections, and if these don't exist in such patients? If AKI persists beyond 7 days, we call AKD. And AKD persists beyond few months, we call CKD. As it persists, the prognosis becomes worse. We know in liver disease, kidney is the tap. If kidney fails, they die. Whether such subcategorization has, number one, implicated therapeutic outcome, change therapy, right, or change your transplant criteria or post-transplant survival. they are important, because unless you implicate them, you see what you do, brilliant people like you, Rakhi and Anjali, Paul, you have confused old fellows like us when you are dealing with this. I want Kausal to respond to that also, because
I thought I made it clear that they will respond, but since you are directing it to me, I completely agree. I think one reason is to make the definitions more uniform so that when it comes to research, these data can be compared. And yes, in terms of survival, it is important that we classify these patients into these groups, because these have survival outcomes, impact on outcomes. So these patients who have HRS-AKI have very high mortality, followed by patients who have HRS-AKD, followed by patients who have HRS-CKD. Yes, in terms of management, in terms of urgency of management, patients who have AKI require urgent management, including liver transplantation, which has to be done within, say, 2 weeks, ideally. But long-term management, I agree with you, may not be different. Can we move forward, or do you want to make a comment?
And more importantly, where do we fit in TIPS here? Not only transplant, so at which stage, SRS, AKD, do you select them for TIPS?
Yeah, so type 2 HRS or HRS, mostly HRS CKD or HRS AKD definitely can be offered TIPS, but not HRS AKI, although there are some trials currently going on that issue. So I think we did talk about significance of urine output criteria, which was recently incorporated, and it was shown that patients who have CKD3 based on urine output criteria also have a very poor prognosis. So this is an important criteria, not just a rise in serum creatinine, but a fall in urine output is also important. So the next question again for the audience, what do you think would be the cause of AKI in this case? He had SBP and then he had renal failure. So is it ATN, it is HRS, is it pre-renal, is it CKD? So show of hands, ATN, HRS, so no renal dysfunction at all. Pre-renal, I'm surprised. CKD, maybe none. So Dr. Piyush, what do you think would be the cause of AKI in this case? Or you want to say it can be mixed?
No. HRS and pre-renal, they are the same things. I mean, HRS is a type of pre-renal failure which will not respond to volume expansion. That is according to the current concept, if Rakhi does not come up with a new definition. So, waiting for, since in this particular case, we have not yet seen the effect of volume expansion giving albumin treating SBP. And again, the issue here is that many of these things which we used to consider as exclusion, they are the precipitating factors like SBP. 30% of patients with SBP will develop HRS. If left untreated, even if you treat them for infections, nearly 10% will go in and develop HRS. So probably in the setting of HRS, now that is a different thing altogether. If there is an infection other than HRS, how does that behave and how does that get factored in the evolution of renal dysfunction and the outcome of renal dysfunction?
Right. So I think the more important thing to remember is that HRS is not the most common cause of AKI in patients who have cirrhosis. It may be hypovolemia, it may be infection, or it may be mixed. Maybe this patient had SBP-induced renal failure. It may be a mixed ATN and HRS kind of picture. Sometimes it may be very, very difficult to delineate the two. And it is important because this is how the prognosis is. Patients who have infection or ATN-induced or HRS-induced AKI, they have a very poor prognosis. And we did talk about the volume expansion reversing some of these patients. So coming to Dr. Dharmender, do you think that one important thing is that it's very important to make an early diagnosis of AKI. The earlier you diagnose, the better is the treatment, better is the outcome. And it's important to differentiate once it is AKI, whether it is ATN or whether it is HRS AKI. So Dr. Dharmender, do we have markers for that? Short of doing a kidney biopsy.
Yeah, as far as biomarker for early diagnosis of AKI in cirrhosis is concerned, we have a couple of them. The most widely used and the most commonly available is the serum creatinine. But serum creatinine in cirrhosis has got a problem because cirrhotics are usually they have very low muscle mass, they have sarcopenia, they have liver dysfunction. So the levels of serum creatinine tend to be a little lower, and hence the EGFR estimation based on serum creatinine we tend to overestimate there. So to overcome this problem, there is another marker which has been proposed, proposed as a superior marker as compared to serum creatinine, is cystatin C levels. Cystatin C levels, while it does not have these problems of serum creatinine, but it has got its own set of problems. That is, it tend to be little higher in patients who have low albumin or who are having underlying chronic inflammation or in the presence of high TLC count. So there is no ideal biomarker. What has been suggested is that a EGFR estimation based on equations which use both of these markers will be a better biomarker.
And differentiating,
differentiating between AT and HRS, yes, here the scientific community is in a better situation, because over the past about a decade or so, there have been multiple urinary biomarkers which has been investigated, and important one among them are the NGAL, the IL-18, the KIM1, and the liver type fatty acid binding proteins. The most investigated among them is NGAL, and that has helped differentiating between HRS and ATN. Of course, there are multiple studies, and I think the value of urinary value of about 220 nanograms is supposed to be having the best accuracy as far as prediction of ATN is concerned.
Right. So I think this was, there have been a number of studies as he pointed out, but this was a recent study, 2023, published in Hepatology, 162 patients, and the levels of NGAL, urinary NGAL, was significantly higher in AKI due to ATN rather than other forms of AKI, and a cutoff of 220 was able to differentiate ATN AKI from other HRS AKI. And this is one study, I got the slides from Dr. Rakhi. It's her study in which they used NGAL to differentiate between ATN and HRS, and patients who would respond or not respond to vasoconstrictor. So patients who had higher urinary NGAL were more likely to be non-responders to vasoconstrictor. Dr. Rakhi, would you want to make a point here? I think we're running short of time, we have to hurry.
Just very quickly, the study we've published now. So we've shown that in the critically ill setting where you're dealing with sicker patients, there cystatin C and NGAL both were evaluated, but NGAL is better marker because it tells us about tubular dysfunction and more about need of RRT, as well as mortality and progression to CKD. That paper we just published.
Right. And is it being done
cystatin C, I would say not in acute setting, but in the outpatient setting,
right,
it is better to be used there, and especially when you're evaluating your patient for underlying CKD or liver transplant. So that one-time assessment could be very useful.
Right. So early diagnosis of AKI, it's cystatin C. Differentiation between HRS and ATN, it is NGAL. But is it being done in ILBS or routine labs?
We do automated NGAL, so the result comes in 2 hours. So it's very helpful in that quick decision making. But cystatin C takes a lot of time.
Yeah, so if anyone wants to send his patients NGAL, they can send it to ILBS. Right. So that's a new information, patient management guideline. So other markers, we talk about fractional excretion of sodium, but it was shown that less than 1% had a poor specificity. What was important was less than 0.2% better predicted extreme sodium retention, and possibly in cirrhotic, fractional excretion of urea may be more important. We don't have time to discuss why. So we move on with the case. Treated for SBP, diuretics withheld, albumin infusion started. Repeat KFT after 24 hours showed a creatinine of 2.12, sodium of 129, low urinary output 400 ml in 24 hours. So now it is truly HRS AKI. After resuscitation there was no improvement, in fact there was worsening. And here I would also want to ask the panelist, how do you resuscitate these patients? How much albumin do you give? The recommendation is 1 gram per kg on day 1. So do we actually give it, this much amount? Anyone from the audience? So no one gives that. We usually give 20 or 40 grams on day 1. So to the audience, what would you start the patient on now? Is it albumin, terlipressin plus albumin, noradrenaline plus albumin, or midodrine octreotide albumin? So terlipressin plus albumin. Okay, most of them. Noradrenaline plus albumin. We've become a rich country. We've reached moon. Yeah. So Dr. Piyush, what would you start this patient on? So the question basically is a choice between terlipressin or noradrenaline.
So now the experts have established that this is HRS-AKI. So the preferred modality, because of the robust evidence that we have, would be terlipressin and albumin, closely followed by NORAD and albumin. Sir, there is a recent NEGM trial which has clearly demonstrated the mortality benefit with the use of terlipressin and albumin. The confirmed trial and this Dr. Sanyal's group combination of two randomized control trial OT401 and reverse trial, which showed HRS reversal benefit with the use of terlipressin as compared to placebo. And over in the same trial, they have shown a reduce in the creatinine value over 14 days with the use of terlipressin as compared to placebo. There have been specific predictors of HRS improvement like MAP. If MAP is rising with the use of terlipressin and albumin, you can say that yes, there is improvement. And other predictors like low serum creatinine, low MELD score are definite good predictors of response to terlipressin. And as the evidence of data is there, majority of the data is for improval in HRS, but with the use of terlipressin, there have been no data of improvement in survival or overall survival.
I think that's a very important point. Although you reverse these HRS in these patients, but you do not make them survive for beyond 6 months or maybe a year. So what makes them survive longer, and we'll come to that later. And we've already talked about the issue of the dose of albumin. These are the studies comparing terlipressin.
Specific meta-analysis which compare terlipressin versus norepinephrine. These meta-analysis are of low sample size, RCTs with low sample size in homogeneous population. So we are not really sure. We need more data to be specifically, but for now, terlipressin would be the first line. In cases where you cannot use terlipressin, like patient develops diarrhea or has cardiac issues, then you can choose up to norepinephrine. Otherwise, terli, I think, would be the first line.
Right. So, Dr. Raki, any particular situation? So I think all of us, I didn't see any hand go up in favor of noradrenaline. So any particular situation where you would prefer terlipressin definitely over noradrenaline?
Patients with acute and chronic liver failure, because we've shown that as compared to decompensated cirrhosis, here terlipressin works much better, even though more adverse effects, but lower dosages will reverse the HRS better than norepinephrine.
Yeah, so this was a study from your center only. Patients who were given terlipressin versus noradrenaline had a better survival and better reversal of HRS. So Dr. Ranjan, I think it's a very important issue. I think something which we ignore a lot. What about the adverse events? You keep on giving them vasoconstrictor. You don't remove their bed sheet, and after 4 days you realize that they've got rashes all over their legs and abdomen. And what adverse events do you expect with vasoconstrictors? And what are the precautions you take before starting?
So most of the adverse effects are very well known to all of us: pain, abdomen, diarrhea, peripheral vascular disease, cardiac side effects, including AMI, atrial fibrillation, tachy and bradycardias. And in the recent confirmed trial, they have come up with one important observation of fluid overload. These patients developing renal dysfunction, and that too even after stopping this thing, and that has been the main cause of mortality even after the stopping of terlipressin. Within 90 days, most of these patients have died because of respiratory failure rather than progressive renal dysfunction or liver dysfunction. And hyponatremia is another enigmatic side effect of this terlipressin, which happens more in compensated people rather than decompensated cirrhosis.
We really see that in patients who already have HRS, more likely in patients who bleed
compensated,
and are
bleeders.
Yeah, and I think this was a very important point which was brought on by this recent study, that patients who were given in the terlipressin group had a high risk of respiratory failure and death due to respiratory failure, 11% versus 2% in the other group. And can these side effects be minimized? Yes, by giving infusion rather than boluses of terlipressin. This was one study which looked at that. The response does not change, but the adverse event profile is lower in the infusion group. We are coming to the end. We just need 2 more minutes. Quickly, Dr. Piyush, can we prevent HRS-AKI?
Sir,
primary prevention,
so
secondary
primary
prevention.
yes, there is data from the ANSWER trial which showed survival benefit, but in a specific subgroup of patient of uncomplicated, not survival, HRS reversal benefit in uncomplicated cirrhotics. And for secondary prevention, there is a recent study from Sharma et al. Of a small sample size, but yes, definitely, in patient who had experienced HRS with the use of midodrine and IV albumin weekly, there was benefit on preventing HRS. So, but we need more data, more robust data in this regards.
Right, this was small study. We do keep talking about after we discharge these patients, what about if we put them on midodrine? So midodrine plus albumin versus albumin alone by Praveen Sharma. So 50% patient in this group had HRS AKI versus 18% in group B. So I think the final issue, Dr. Dharmender, would you refer this patient for liver transplant? And what would be the timing? What would be the contraindication?
Okay. So liver transplant, yes, because development of HRS supported reduced survival in these patients. And by doing liver transplant, you are curing the liver disease and portal hypertension, which is the cause of HRS. And if you choose the time carefully, in majority of cases, you will reverse the renal dysfunction also. So the answer to the question, transplant, yes. Now the second question, when? When there is enough data both from the east and the west that there are three factors which predict the reversal of liver dysfunction in post-transplant patient. And these factors are the duration of renal dysfunction, the duration the patient was on hemodialysis, and so these patients who are on prolonged dialysis and who had longer duration of renal dysfunction, the reversal of renal dysfunction is little less. So the timing should be as early as possible so that you reduce these two variables.
Right, a very important point, because many of these patients have a mixed HRS ATN, and you can see that even patients who were initially classified as ATN, almost 50 to 70% of them reversed their renal failure after liver transplant. So that seems to be the most definite treatment. If you look at this particular study by Boyer, 99 type 1 HRS who were randomized to terlipressin versus placebo, without transplant, the 6-month survival was not different, whether they reversed or did not reverse their HRS. But if they were given transplant, it did not matter whether they received terlipressin or placebo, 100% versus 94%. Again, transplanted patient, 100% survival. HRS reversed, not transplanted, only 40% survival. HRS not reversed, not transplanted, 0% survival, or maybe less than 5% you want to say. So what gives them survival is transplant, and the survival is not different between HRS patients and non-HRS patients who are transplanted, because there is a concern that patients who have renal failure will probably have a poor survival, so that is not true. So, just last point, do we want to make that, or I think we are running short of time. I think Dr. Acharya did make that point that if it goes on, it becomes CKD, but I think Dr. Rakhi would want to differ on that, and we can have more discussion later. So that the final point is that AKI progresses to CKD. So more the number of episodes of AKI, more likely the patients will develop CKD later on. But CKD defined as the criteria mentioned earlier, more than 3 months of GFR less than 60. Am I right, Rakhi? Yeah. So these are the take-home points. Prerenal azotemia and infection-related ATN are equally common causes of AKI in cirrhosis. Do not think only of HRS, think of these also. Early diagnosis of AKI is the key for treatment and prevention of mortality. Use KDIGO guidelines, which uses creatinine as well as urine output criteria for identifying these patients early. Biomarker, cystatin C for early diagnosis of AKI, NGAL urinary for differentiation of ATN from HRS. HRS AKI best managed with vasoconstrictors and albumin. There will be a debate about how much albumin to give. Terlipressin, small number of studies has been shown to be equivalent to noradrenaline, but in ACLF, terlipressin is superior. Be aware of the adverse events. We might be losing some of these patients to these adverse events, which we are ignoring. All patients with HRS AKI should be referred for transplant early. That is the only treatment which offers good survival. Outcomes of liver transplant for HRS is almost as good as non-HRS. Reversal of AKI occurs in 70 to 80% patients post-transplant. earlier done, the better, preferably when the RRT has been applied for less than 6 weeks. Thank you for a patient hearing. Done. Thank you. Thanks to the panelists. Thank you.
I would like to call the chairpersons for next session, Dr. Narinder Chaudhary, Senior Consultant Gastroenterology and Hepatology, Medanta Hospital, Gurugram, Dr. Puneet Mehrotra, Consultant Gastroenterologist, Neera Hospital, Lucknow, Dr. Yashwant H, Consultant, Bangalore Baptist Hospital, Bengaluru, Dr. Nishant Verma, Consultant, Jeevan Raksha Hospital, Bikaner. I will like to invite the panelists also. Dr. Mukul Rastogi is Additional Director, Gastroenterology and Liver Transplant at Fortis, Noida. Dr. P.K. Sharma, Consultant Gastroenterology, Command Hospital, Kolkata. Dr. Rohit Sharma, Additional Professor, Gastroenterology and Hepatology at AIIMS, Rishikesh. Dr. Sunil Chakravarti, Consultant Gastroenterologist and Hepatologist, M.I.C.E Hospital, Saket. And our talk will be a case discussion based refractory ascites in patient with the HCV cirrhosis, and our speaker is Dr. Akash Shukla. Dr. Akash is Director Gastroenterology and Hepatology at Sir H.N. Reliance Hospital, Mumbai.
Good afternoon, everybody. At the outset, I must thank Professor Acharya sir and Dr. Pankaj Puri and the organizing team for inviting me here. So, can you allow me to move the slides? Yeah. So, without much ado, I'll start the case. This is a 45-year-old gentleman who has come with ascites and edema feet, which is progressive for the last 2 months. There is no pain in abdomen. He has history of significant alcohol consumption. He has been abstinent for the last 2 months. His decompensation has been in the form of ascites and 1 episode of bleed right at the onset, for which a banding was done. When he comes here, somebody is adjusting the settings. So, when the patient comes, blood pressure is 112/60, edema feet grade 2, no other significant findings, systemic examination okay, abdomen shows free fluid and just palpable spleen. On investigation, this patient is on, has bilirubin of 2.2, INR of 1.5, creatinine of 2.0, sodium of 131 and albumin of 3.1 grams. An ascitic fluid analysis is done which shows albumin of 1.9 grams, cell count of 210. Ultrasound with Doppler is done which shows no portal vein thrombosis, no HCC, there is portal hypertension and cirrhosis. 2D echo is done which shows grade 1 diastolic dysfunction, pulmonary arterial systolic pressure of 28, other things are normal. He is HbSAg negative, anti-HCV positive, the RNA is 6.4 logs, genotype 1. Now this patient has been receiving diuretics empirically before he has come, he is on lazilectone. So at this stage, I would want to ask what would be the approach of the panelists. You can start with Dr. Mukul.
So, we are dealing with a case of hepatitis C related liver cirrhosis with superadded alcohol use disorder. So, he is decompensated since 2 months with edema and ascites and started on diuretics. And after starting diuretics, there is development of renal dysfunction in this patient with a creatinine of 2, and ascitic fluid analysis is suggestive of high low albumin ascites, which favors portal hypertension. And Is this patient started on antivirals? DGH?
No, not yet, not yet.
Not yet.
Not yet.
Okay. So this patient is having high creatinine, so we have to stop diuretics, number one. And sodium is 131. And number two, we have to start him on albumin infusion because creatinine is high and bilirubin is also high and INR is also high. So there is additive advantage of giving albumin in such patient. And we have to start him on, this could be, we have to first rule out whether we are dealing with hepatorenal syndrome or diuretic insult. So we have to rule out that, and then if there is hepatorenal syndrome, we have to treat this patient with vasoconstrictor, terlipressin and albumin.
So absolutely right. So I think we have discussed this point in a lot of details in the previous talk, that we are dealing with acute kidney injury here. The baseline creatinine was normal, it has increased to 2 after the use of diuretics. So, I'm sorry, so the urine spot was 120, the potassium was 40, IVC was 10 millimeters collapsing, albumin was given for 3 days, the beta blockers were stopped, the diuretics were stopped as well, and the urine output increased on day 2. And the creatinine after 3 days was 1, and the sodium had increased to 130, the potassium was 4.6. So this patient was started on sofosbuvir plus velpatasvir, and for ascites, he has been treating on, furosemide plus spironolactone 100 milligrams per day. Patient has already been counseled about the salt-restricted diet. Patient has been compliant to salt-restricted diet, which has been confirmed with the relatives. So now, this is anything else that you want to do? This patient is still having ascites. So can we have the next panelist, please? So ascites is persistent. We have started on sofosbuvir plus velpatasvir. He is on 40 milligrams of furosemide, 100 milligrams of spironolactone. The ascites is still persistent.
But it is not increasing.
It is not increasing, it is the same.
Persistent with the present medication.
Yeah.
Okay. So he is stopped alcohol. What about his LFT, bilirubin and all?
Still the same, 2.2.
Okay. Now the present problem being ascites control. He's been already started with the definitive treatment for his etiology, one of the etiology. That was hepatitis C. So we have to wait. I think that will also show response over a period of time. But if you see his MAP is little low. Yeah. MAP is low, and if his ascites is not responding, I think here in midodrine can be added for ascites control. That's what I'll add on that this stage.
Yeah. So would you want to, how will you prognosticate that this patient is going to improve to an extent that he becomes CTPA and compensated, or somebody who has stopped alcohol is put on hepatitis C treatment, or this patient is going to remain decompensated and would eventually need a transplant? So how do you really differentiate?
So, sir, if you see this patient, he has been on diuretics and still his ascites is persistent. So one way to go about it will be to go for his urine, 24-hour urine sodium or a spot urine sodium or potassium sample. Now if this ratio is more than 1, then it indicates that he has adequate natriuresis. If despite that the patient is not losing weight, then it indicates that there is excessive salt intake by this patient. And this history may not be forthcoming from the patient of salt consumption. So because we know that certain bakery products which patients consume tend to have added salt, which this person can consume inadvertently and can cause ascites to be persistent.
Okay. But again, coming to my question, that when you're treating somebody for Hep C, can you predict at baseline whether this patient who is currently decompensated will improve to such an extent that he will become recompensated and will no longer require a transplant?
Yeah, there is data in patients with decompensated chronic hepatitis C, those who have been on waiting list, and after treatment with DAs, a small percent of patients have actually improved, their liver functions have improved, their ascites has improved, and they have been delisted from the transplant.
Yeah, so almost 40% of patients who are CTP-B and almost 20% of patients who are CTP-C will improve. Perfect. So now, on subsequent follow-up, this patient has further increase in ascites despite diuretics and compliance. Now we have reached a diuretic dose of furosemide of 160 milligrams and spironolactone of 200 milligrams. It is required repeated tapping every 15 days for the last 3 months. Patient is already counseled about salt-restricted diet and is compliant to this salt-restricted diet. Relatives have confirmed compliance to salt and water. The blood pressure is 110/65. There is no postural drop. Creatinine is 1.1, sodium is 129, and potassium is 3.9. So at this stage, would you again stop the beta blockers? So I would want each one of you to take one question. Increase spironolactone, add tolvaptan, change the diuretics, and restrict the fluids, or do all of them. So
we'll be stopping the beta blockers because his ascites is getting more refractory. And regarding increasing the spironolactone, already had earlier probably a diuretic-induced increase in the serum creatinine. So increasing spironolactone would need to be done very cautiously. He's already responding. One good thing is that he has a good natriuresis. So I'll probably increase spironolactone and then check his creatinine more carefully. Because as far as the furosemide is concerned, he received 160, but spironolactone dose is, I think we need to increase to 300.
So practically, how many of us would ever really cross 200 milligrams of spironolactone? So go to 300 or 400?
It would be very, not very common, but even for the furosemide dose to go up to 160 is not very common, and surprisingly, he is tolerating it well. His creatinine is maintained on that. So why not give a little more chance that increase spironolactone and see if he is not responding?
Yeah, so theoretically, absolutely, yes, you are still permitted to go up to 400 as per the definition. I think that is also an arbitrary cutoff. If the patient is holding on, we can probably go beyond that also. We don't know. But the practical thing is, I mean, somebody who has not responded to 200 is unlikely to respond to 300. So, and here is a patient whose ascites is increasing. So what about other options? Would you add tolvaptan? Because now the sodium is 129, the maps are still good.
Actually, now we are dealing with a case of refractory ascites. Because there is requirement of repeated large volume paracentesis in this patient. So once a patient develops refractory ascites, we have to withdraw all diuretics. So we have to stop furosemide, torsemide, spironolactone. Every diuretic should be stopped. And sodium is low, that is 129. So we have to restrict, because this is hypervolumic hyponatremia. So we have to fluid restrict in such scenario. And tolvaptan can be used in such scenario, but cautiously, because there are a lot of studies on tolvaptan which increase the free water clearance in the collecting duct. But its use should be in child C cirrhotic. It should be cautiously used in child C cirrhosis. So fluid restriction, stopping of diuretics, stopping of beta blocker, and one can use tolvaptan if sodium is not increasing. And if a patient is planning for transplant, we have to give 3% saline for increasing that. So we have to do fluid restriction at this.
Yeah, so I think here we are dealing with a patient where despite treating Hep C, despite patient being abstinent from alcohol, despite the patient being salt compliant, you are still having progressive ascites, which is not common. Once you treat the etiology, usually you would expect things to improve. Although among the alcoholic liver diseases, it is a described phenomenon that you may have a transient worsening of portal hypertension for the first 4 to 6 weeks after stopping of alcohol. But now this is almost 3 months and it is still worsening. And as you very rightly said, we have to, because there is hyponatremia, we would restrict the fluid intake. We can consider adding tolvaptan with caution, especially it has to be supervised very closely. Our patient has had a bleed also, so that makes the patient at a higher risk of complications with tolvaptan. And we are already on a very stiff dose of diuretics, so we don't know really whether adding any diuretics more, increasing the dose helps. It is also the change in diuretics people try. A practical experience is when you don't get diuretics response with a particular type of diuretics, you always try to change, and sometimes you get a good response with metolazone. That has been our experience, so you can give a trial. But all these are options. Again, no data to back any of these things. But so in this patient, we stopped the beta blockers. We decided to investigate this patient further as to what is going wrong. Urine routine showed no UTI. Urinary spot sodium was 130 millimoles of diuretics. The MR abdomen was done to rule out HCC, portal vein thrombosis, and hepatic vein thrombosis, and there was nothing. Ultrasound showed normal sized kidneys, maintained CMD. 2D echo was done, which was normal to rule out any cardiac pathologies. So, do you think it is the right time to do a TIPS or transplant or investigate further? What does our audience feel? How many of you would consider TIPS for this patient now? Okay, quite a few. And how many of you would think that now this patient should be transplanted? Great. So I think most of you. And anybody to investigate further? Okay. So what investigation would you want to do? Means salt intake? Yes. Okay, perfect. So this patient is in the hospital, supervised diet, and it's confirmed that the patient is salt compliant. But as you very rightly said, the urinary sodium is high, 130 of diuretics also, which is quite surprising in somebody who has got refractory ascites. In fact, you expect it the other way. But we decided to investigate further. And one of the important checklists before you subject the patient to anything major is to retest the ascitic fluid to be sure that there is no infection in the ascitic fluid. And here we repeated the ascitic fluid. It showed albumin of 1.8 grams, cell count of 430, 88% lymphocytes, AD of 46. Cultures, including fungal cultures, came back negative. The SAG was 1.2. Other parameters were okay. To look for tuberculosis elsewhere, we did a CE-CT abdomen, which showed just cirrhosis with portal hypertension, no lymph nodes, no evidence of any peritoneal thickening. HRCT thorax was done, which showed just mild bilateral tiny pleural effusions, no evidence of lymph nodes or tuberculosis. IGRA was negative. So 430 cells, 88% lymphocytes, AD of 46 in a patient who is child B9. What would you do? So, would you do a diagnostic laparoscopy? Would you start empirical ATT? Or would you do some other test?
So, I would consider a possibility of mixed ascites in this case. His cell count is predominantly lymphocytic, his AD is pretty high, and diagnostic lab will require a general anesthesia in a patient with child B cirrhosis. There will be possibility of precipitating his ACLF. So I would go ahead and start him on second line ATT.
Okay. So how many of you would start ATT for this patient? Okay. And others? Laparoscopy. Okay. So we did a diagnostic laparoscopy for this patient. White peritoneal nodules, 8 to 10 in number, largest around 1 centimeter size. Multiple biopsies were taken. Histopath showed caseating granulomas. Gene expert came positive for tuberculosis, no resistance. Now, coming back. So, you have to now give ATT to this patient who is on sofosbuvir velpatasvir. He is a CTP B cirrhosis. So, how will you give ATT? What will be the regimen that you would give? We cannot give rifampicin with sofosbuvir, so we have to give a non-rifampicin based therapy. So
non-rifampicin based ethambutol, quinolone, and maybe INH can be given, INH ethambutol.
I think that's a very fair combination that to give. What we decided was to give isoniazid, ethambutol, moxifloxacin, as you very rightly said, plus terazidone. So we could have used cycloserine, that would have been the other option, but terazidone is safer from the neurology point of view, very similar action. So this is what we started the patient on. The Hep C therapy was continued. Patient remained abstinent from alcohol. Over the next 2 months, the appetite of the patient improved, the sarcopenia improved, started doing well in general. The LFT actually improved. The bilirubin was 1.2, albumin increased to 3.6, INR was 1.2, SGOT of 28, SGPT of 32. The ascites did not respond. He was still requiring tapping almost once in 15 days. And he was compliant to salt. So what would you do next? So we had thought that, once we start ATT, this patient would respond for the ascites also, because we detected TB in the peritoneum.
So in this scenario, we have to rule out some other cause also, some other etiology of the disease. It could be some peritoneal malignancy, which is pouring ascites.
We have done a diagnostic laparoscopy and biopsy. This is now almost 2 months. I think that's a very, very valid question, whether we can repeat. So we decided to investigate this patient. Doppler was normal. We repeated ascitic fluid, which showed 2.2 grams of albumin. SAG was 1.4. WBC count is now down to 34. ADA is down to 5.2.
It's not developing chylous ascites.
No, it's not a chylous ascites. It's a very clear low protein, moderate protein ascites. We did repeat a 2D echo to look for other causes. The urinary sodium, we repeated 24 hours. As Dr. Ashish had suggested, it was 280 millimoles for 24 hours. Now, this is still in the hospital. Somebody who has got tense ascites, high urinary sodium. The urine osmolality was 390 milliosmoles. And it was a supervised diet, which confirmed that no salt was being given. So we're really flummoxed at this stage, just like all of us are. It was a complete bouncer for us. So again, the same questions came. Should we do a TIPS, transplant, or do some more investigations? So the easy way out for us was doing a TIPS. We actually had a long meeting with the family. The problem was, I was not comfortable offering TIPS to this patient because I didn't have an explanation for this ascites. No, we didn't do a liver biopsy. But what would we be suspecting? Clinically, not like sinusoidal obstruction. So 2.2 grams proteins in the ascites. Normal. So thyroid function was done, it was normal. I agree with you, sir. That is what we were also very worried. And that's why this was in the hospital supervised at every diet coming from the hospital. So like you said, we suspected. So this is where I have learned from Dr. Acharya, sir. We decided to taste everything that was being given to the patient. So we started with the protein supplements, BCA powder, sugar plus lemon extract. And to our surprise, it was actually the protein supplement, which tasted salty. So once we stopped the supplement, the patient responded, ascites resolved in 15 days. So it was a protein supplement, and on the ingredients, it was mentioned that 30 gram serving has only 65 milligrams of sodium. Then I did a literature search, and then I found this analysis done by a company, independent company called Lebdur in USA, which did analysis for 81 protein supplements in the USA. They were the top 81 selling protein supplements of USA. 70 were found to contain higher sodium content than their nutrition facts claimed. 50 of these protein powders and drinks exceeded their claims by an alarming 91.7%. And one of the brands there was the worst offender, understating its actual sodium content by over 350%. And the next statement by the CEO of Lebdur was very interesting. These errors go way beyond simple manufacturing variance. It is clear that supplement companies have chosen to misrepresent their health claims, and without any pre-market regulation by the FDA, they have gotten away with it until now. So these come under, even India, under nutraceuticals and not under the FDA regulations. The important thing for us to remember here is that why they increase the sodium content in the protein supplements. For those who are regular gym users, actually high sodium content increases the body weight because of the fluid retention, and that causes a false sense of weight gain and muscle bulk. And that is the reason why they have been adding high salt content to the nutritional supplements. So this is what we have to remember in our practice. So this is what happened to our patient, where everything else was sorted, and because of he was given by one of our overzealous, one of my co-consultants who was very enthusiastic about diet, was giving 4 scoops 4 times a day of protein supplement to this patient. And that is what the patient was eating, and that is what led to. So what are the surreptitious salt intakes? Well known are the pickles, rock salt, black salt. We face this question every time that I don't eat salt. I eat sendhwa namak, I eat kala salt and different types of salt. The other is sauces like soy sauce, barbecue sauce, tomato ketchup. They all contain very high salt content. Seafood naturally contain very high salt like prawns and shrimps. All your packaged products, they have a very high salt content because that is how they preserve, that is how they prevent the decay and fermentation. So all the pre-packaged soups, hams, cheese, juices, fish and poultry. Bakery products like bread, sandwiches and pizzas, pastas and hummus. Effervescent tablets, very common. So again, many of our patients, when they have acidity, they consume a lot of these effervescent powders or tablets or soda, and they are all rich in sodium. Dried fruit powders, very commonly, 4 years ago I presented one case in one of the meetings, again Dr. Acharya sir had guessed rightly, it was amchur powder. Patient was adding amchur because he was on salt restricted diet, and amchur powder, although the packet did not mention salt, it did have a lot of salt. And now we have to also be careful about the protein supplements. So this was a learning experience for me. So the checklist before we label anybody as refractory ascites: salt compliance on history, dose of diuretics, hypovolemia, vascular issues like portal vein thrombosis, look for drugs like methotrexate, cardiac dysfunction, beta blockers, has to be stopped, rule out infections like tuberculosis in our case, all surreptitious salt intake possibilities, and it's a good idea to taste everything that the patient eats before we label this patient as refractory ascites when you have exhausted the list. Thank you very much. I'd like to thank the panelists. Any final comments or from the chairpersons or the audience, sir?
I was wondering, before proceeding on to tips, did you consider twice weekly albumin? Not in this case.
This patient was on weekly albumin.
Twice weekly
so
albumin or midodrine as a treatment.
Yeah, so we give weekly albumins. We usually don't give bi-weekly. So the first week we usually will give twice a week. But here was the serum albumin was 3.6 in this patient. The 3.6. So I mean, to increase it to beyond more than that, I don't think. So we are always suspicious that, something is going wrong. That's why at every level I have said we have checked for salt compliance, and we were fooled.
Albumin in this patient would not have helped from the beginning. The albumin was 3.4. And with albumin of 3.4, we see refractory ascites is very unusual in cirrhotics. And that is the first indicator in this particular patient that there is something else. There is a wrong. And achar, papad, chutney is normally not considered as the diet. And that is the usual thing. But another thing, in India also Albucare and oroalbumin which are prescribing, because they have also salt.
Yes, absolutely, sir.
They have also salt if you check it very carefully. Because it is a blind prescription, Albucare and oroalbumin. right? They have also salt. The best is to give them the eggs, right, without salt, right? That's natural.
In this case, probably the initial unresponsiveness was because of tubercular infection, and subsequently you put him on high protein, high
Absolutely.
salt
High protein.
supplements, and that caused refractory.
Yeah.
I remember once you had presented a case in which patient was saying there's no taste in the food, so I'll take one hajmola at the end.
Yes.
And that was the problem.
Yes, sir. Once Amchur, Hajmola, we have had means all combinations, believe. Yeah. Thank you. Thank you very much.
Thank you, sir. I request the chairpersons and panelists to please be seated because there is another talk on chronic liver disease and decompensation. The speaker for this talk will be Dr. Sunil Taneja. He is a professor in hepatology at PGI Chandigarh. He will be talking on therapy of hepatitis B and C in decompensated cirrhosis. Does it improve survival and prevent complications?
Good evening, everyone. At the outset, I would like to thank Professor Acharya sir and Professor Puri for inviting me here. And my job here is to talk about therapy of hepatitis B and C in decompensated cirrhosis. Does it improve survival and prevent complications? Okay, so why treat decompensated cirrhosis? What are we trying to achieve? One is viral eradication. The kind of antivirals we have for B and C, we are able to achieve complete viral eradication now. So the whole idea is to improve the hepatic functions, which might improve the quality of life, and the liver-related complications will come down. So other aspect is you're trying to improve the MELD and the CTP scores also, so that these patients can be taken off from the transplant list. Thereby, you're trying to reduce the burden on the liver transplant waiting list, and you're trying to save an organ. Then you also want that patients should have a good survival, they should not get HCC, and this new concept of recompensation. Once you have decompensated liver disease, they might just come back to that compensated state, which Bavino 7 now defines that if you are suppressing the primary etiology and you're taking care of complications, they might come to that compensated state. And if it is continued for a period of more than 1 year, then you say that they are true recompensation. So let's just look at the natural history of HBV-related cirrhosis. We all know that compensated cirrhosis will progress to decompensation, and then they will go on to develop complications. And subsequently, some will either go to transplant, or others will develop HCC, and then obviously either they will be treated or transplanted, or so on. They will be on management for that. And there is a lot of data which says that liver disease may continue to progress and decompensation or HCC may occur, especially in cases with active viral replication. So the whole idea is to bring down the viral replication so that the patients do not develop decompensation. And in compensated state, decompensation may occur at the rate of 2 to 5% per year. The survival in compensated liver disease is 5 years is around 84%, and if it is decompensated, the survival comes down to 14 to 30%. Now let's look at this data. This is data from the Korean insurance cohort, and this is a huge database which they had, a recent paper. Out of 286,000 patients, these were all patients who were given antiviral treatment, and this was without cancer, 165,000, and they included the compensated group and the decompensated group. And in this decompensated group, treatment naive were 7,166, and patients who were given treatment were around 2,682. So let's see what happened. In the treatment naive, the HCC occurrence was seen in, at 5 years was 24%. Death was seen in around 32%, and second decompensation was seen in around 60% of the patients. And we all know that compensated cirrhosis would progress to decompensation, and the rate which they got was around 7.4% at 5 years. And same is for chronic hepatitis, 11.5 years over the period of 5 years. Now let's look at the role of antivirals, patients who were given antiviral treatment. In decompensated cirrhosis, the second decompensation came down significantly. It came down to 3.4% at 2 to 5 years. The annual incidence of HCC in decompensated cirrhosis came down again significantly to 2.5% over 2 to 5 years. And look at the annual mortality rate, significant reduction in the mortality from first year to 5 years. So that makes a case that we should treat patients with decompensated cirrhosis Not only you're decreasing the second decompensation, the annual incidence of HCC is also coming down, and the mortality is also coming down. Now let's look at another paper. This is entecavir for patients with Hep B decompensated cirrhosis. This is a meta-analysis, and this included 26 studies, a very good control of viral replication, normalization of ALT is seen in almost all the patients, and look at the survival. Definite evidence to suggest that the survival improves with antiviral treatment. Another paper, the clinical effect of antiviral therapy in patients with Hep B related decompensated cirrhosis. Now this is a different group. Here you have this undetectable DNA. Now what they did, they divided these patients into patients who were given antiviral treatment, and the second group, 379 patients in which no antiviral treatment was given. In patients who were given antiviral treatment with undetectable DNA, there was no difference in the cumulative incidence of death as well as HCC. So if you have undetectable DNA, they didn't show any benefit. So the case they've made here is that undetectable DNA, you can just wait, you don't need to treat. The only query or the caveat here is that sometimes you can have flare of Hep B, which can lead to further worsening. So this is the crux of Hep B treatment. What they have seen in all the studies, the LFTs will improve, DNA will come down, obviously you will get those undetectable DNA. The child and the MELD scores definitely improves. The risk of HCC does come down, but in decompensated cirrhosis or persistent cirrhosis is a risk factor for HCC. And obviously the need for liver transplant it's going to come down if you treat them and if there is improvement in liver functions. And death is also less if they are treated. So to summarize for Hep B, there are limitations of antiviral treatment. It controls viral replication very well. About 30 to 70% of the patients have significantly improved liver functions, suggesting that decompensated Hep B can be recompensated. This will lead to improved survival also. And as I said, if you control the HBV replication, HCC is also going to come down. But then there is some data which says that HCC is going to stay there, and since cirrhosis per se is a risk factor for development of HCC. So quickly now, treatment of Hep C in decompensated cirrhosis. Now we all know that again, if you look at the natural history, chronic Hep C will progress to cirrhosis over the next 25 to 30 years, and HCC will happen in 1 to 4%. At the face of it, if you look at this table, if you have SVR with treatment, the overall mortality will come down, HCC also comes down, and the portal hypertension related complications also comes down. Primarily the patients which have been taken in these studies are either they are child B or early child C. So let's look at this data in decompensated cirrhosis. The treatment response to antiviral is very good, we all know this, varying from 80 to 94%. The recent data on SOF-Velpa and ribavirin, it shows that the response to treatment is more than 94%. But look at this, the number of patients in child C cirrhosis in all these studies is very less. So the only caveat here is that if you have advanced liver disease, the response to Hep C treatment might not be as good as in patients who have early decompensation. Let's look at this HCV target cohort. And in this, they divided the patients into 3 groups, MELD 10 to 15, 16 to 20, and MELD more than 21. Look at the response, more than 90%. So that makes the case that you should treat all patients with decompensated liver disease. In all the 3 groups, the response was more than 90% with the newer antiviral treatment. Now, SVR rate more than 90%. Not only the SVR rates, the short-term survival was better. There was a 24% reduction in the MELD score by more than 3 points. In long-term also, a clinically meaningful decrease in the MELD score of more than 3%. 3 occurred in 29%. And a final MELD score of less than 10 was achieved in 25%. That's significant. However, they also saw one thing, that over a period of 5 years, this mean change in MELD and albumin was just marginal. And what they said that was, if the ALT is less than 60, if they have CTP score C and MELD more than 16, then the response to treatment might not be very good and the development of complications might not be different. Can I have my slides? They're not moving. I'll take 2-3 minutes. Okay. So this is a recent paper from Brazil, and 130 patients, 3 years follow-up. Decompensated cirrhosis, they showed that if the MELD is high and they have ascites after the treatment, then the survival is less as compared to patients who recompensate. And if they continue to have that decompensated disease, they should be evaluated for liver transplantation. Now this is the data from France, 600 patients, and they have shown that HCC, all-cause mortality, liver-related mortality, even non-liver related mortality comes down if you treat these patients with DIAs. And just look at this figure. HCC in patients who are not given DA is maximum as compared to patients who are given DA, and same is for survival and same is for transplant. So patients who are not treated will go more towards transplant rather than who are treated. So a very interesting paper. In this, they have seen the progression of disease and the improvement, the kind of recompensation which we now define. 622 patients, primarily CTP-B patients, and 120 were CTP-C. Now, the MELD score was primarily more than 15 in 151 patients. And look at this. Over a period of time, after treatment, there was a reduction in 31% of the patients to child A status from child B. And in child C cirrhosis, only 12% of the patients came back to this child A cirrhosis. And what they saw that if there was no NCAF, no ascites, if the albumin was more than 3.5, ALT was more than 60 and BMI was less, they had a better prognosis and they had a better chance of getting back to the child A status. So what are the pros and cons of treatment of HCV in decompensated cirrhosis? We know that SVR is very good, liver functions will improve. This may obviate the need for liver transplant. You're trying to save an organ from the organ pool. You're preventing LT HCV recurrence, and you have less drug-to-drug interactions when you have to treat these patients. And this is the only option in most of the countries where transplant is not available, especially in countries like India. And obviously, if you treat them, then the HCC can also be treated after that. What are the cons? Now, you are trying to eliminate the opportunity to give a curative treatment of liver disease and place the patient into MELD purgatory. So that what they're trying to say is that there is an improvement in MELD, but not to an extent that they will not require transplant over a period of time. And no one is looking at the quality of life of these patients. So by giving treatment, they are coming to a stage where there is an improvement in some quality of life, but not to that extent that they are absolutely fine. So still they are at the risk of progressive liver disease and HCC. And this precludes the use of HCV positive organs. So now HCV positive organs are being given to the decompensated HCV disease. So if you treat them before transplant, then HCV positive organs cannot be given. And obviously we know that treatment of LT is associated with higher, after LT is associated with higher SVR rates as compared to treatment in patients with decompensated cirrhosis. And those who fail therapy, then you have limited options to treat after transplant. So the two key questions which were there, to what extent is treatment of patients with decompensated cirrhosis beneficial in improving hepatic function and quality of life? I've shown you that data. But then the caveat here is that if you have to give HCV positive organs to HCV negative, once they are HCV negative, then you can't give those organs. So what is the proposed algorithm? If you have decompensated cirrhosis, if you have lack of access to liver transplant, treat all patients. And if the MELD is less than 15, again, you treat all patients. 15 to 25, case by case discussion. If they are a candidate for transplant, you can wait. If not, treat, wait and see if there's improvement in the liver functions. They might escape liver transplant. If not, they should be subject to transplant. And if the MELD is high, then you can transplant them straight away and treat later on. So let me just summarize. Hep B antiviral therapy is safe and effective in restoring liver functions and improving patient survival. This may not prevent the occurrence of HCC in decomp cirrhosis. And in Hep C, DA in decompensated cirrhosis leads to high viral clearance. It improves the liver functions and health-related quality of life, but not to an extent that they might escape transplant. It might slow the disease progression, improve survival, and we all know that DAs are very safe. Thank you very much for your patient listening.
Thank you, Dr. Sunil. So in sick hepatitis C patients, it is better to do transplant first and treat later. Up to what MELD cutoff you are happy to treat?
So the literature suggests that up to a MELD of 20, you can treat these patients before transplant. But if it is more than 20, then ideal is to do a transplant. But then in a country like India where transplant is limited, I think we should treat all patients with Hep C. So that's my thought.
In MELD 18 to 20, there is also a risk of waitlist mortality on treatment.
Yes, yeah, true.
Questions? We close this session. Thank you.
Thank you very much.
Thank you, sir. Moving on, our next session, fatty liver, what's new, nomenclature and therapy. Our speaker, Dr. S.P. Singh, Professor and Head, Gastroenterology and Hepatology, SCB Medical College, Cuttack. Please welcome our chairpersons, Dr. Anup Saraya, HOD Gastroenterology and Hepatology, AIMS, New Delhi. Dr. Madhu Mitra, Hepatologist, PGI, Chandigarh. Dr. Munish Sachdeva, Senior Consultant, Gastroenterology, Sir Gangaram Hospital. Dr. Naresh Bansal, Professor, Gastroenterology, Sir Gangaram Hospital. Dr. Sanjay Khanna, Director, Gastroenterology, Fortis Shalimar, New Delhi.
So I would like to invite Dr. S.P. Singh as the first speaker in this session, and his favorite topic, fatty liver, what's new, nomenclature and therapy.
Good afternoon. So at the outset, I thank the organizers for inviting me for this lecture. Fatty liver, what's new in nomenclature and therapy? It's too big a topic anyway. I believe when they have written fatty liver, I think time is short, I'll be jumping. What they have meant is fatty liver. By fatty liver, they have meant this NAFL, whatever, I mean, that's what they have meant. They have not meant, you know, there's so many types of fatty liver. So, I'll be speaking on NAFL, what's new in nomenclature and therapy. And a bit about nomenclature and then about therapy. First, nomenclature. The name of NAFL, I'll be referring to NAFL in general. I'm used to, and it won't go away so fast. So from NAFL, it's gone on to MAFL, then to MASL. These are the people who started all the problem. A paper was published in Gastroenterology, a consensus-driven proposed nomenclature for metabolic associated fatty liver disease. People who understand English would know that you don't have metabolic associated fatty liver disease. You can have metabolism associated, or you can have metabolic fatty liver disease. They realized it, and then they changed it, you know, dysmetabolism or metabolism, whatever. But no sooner was this published, there was a split in this group. There was a split, and off walked, you know, a big group, a big chunk just, you know, walked off. This was their definition of, you know, that MAFL. Person should have hepatic steatosis, should be overweight or obese, or have diabetes mellitus, or if he is lean or has a normal weight and has fatty liver, then if he has at least 2 of the 7 factors, from where they got the list of the 7 factors, I don't know. I don't think there is a scientific basis for this. But anyway, these days in the race for, you know, publishing, a lot of unscientific things get published. So, even then, if you have 2 of 7, then that qualifies as MAFL. Now, this big chunk, they are virtually the, who's who of NAFLD in the West, west of India. Yunosa, Rinela, Sanyal, Harrison, Brunt, Goodman, Cohen, Lumba. Only people left out are Jacob and Sareen and, a few more. Professor Chawla is left out. So, they immediately, short of this, commentary, it's premature. If it was premature, what were you doing in that group which published it anyway? We published this in JHEP, non-alcoholic fatty liver disease, not time for an obituary just yet. Professor Duseja also jumped in. He said not only premature, change in name is confusing also, very, very confusing. And there were at least a dozen reasons he put forth for that. I thought that since, this entire name change, when you go through it, part of it was, that, this is a negative thing, you're non and all that, but patient-centric. Patient is feeling hurt. That, you are telling him fatty, you are telling him alcoholic. It is non-alcoholic, you don't take alcohol. But somehow or the other, they got this onto it. In fact, I wrote repeatedly to them for a clarification. How did you get about the patients, what the patient feels? They didn't reply to 3 queries sent to them thrice. So we decided to do a survey in South Asia. 5 countries were involved. What do our patients feel? And what we found was they were perfectly comfortable. 80 to 90% want NAFLD to stay. That non and the alcohol business and on, they were happy because, why were they happy? Because, once they get a label of NAFLD, मैं दारू नहीं पीता हूँ. You don't get repeatedly hammered, कितना पीते हो, क्या पीते हो, but in this current diagnosis, that will continue. How much alcohol you take, it is methyl predominant, it is metal, it is what, it will go on now. Again it will start off. People are going to follow this. Then we had this NAFLD, we had this INASL consensus meeting. Again here, it was a no-no. The term NAFLD should not be changed to MAFLD. This was the consensus of INASL. But, hepatologists, amongst all the, I believe, amongst all the specialists, hepatologists are the most dangerous breed. See, we have a sort of a World War I, World War II going on. ACLF thing is not yet over. You talk to them privately, you will get, you will come to know the key place, how they use such words for each other. And now we have NAFLD. So, from MAFLD, gradually now we were coming to a new terminology. What the terminology would be, how the patient would not feel bad, how he'll feel good, and how it will convey. And I mean, you had a lot of reasons for, and ultimately, we were coming to this term MASLD. No sooner did the, parties come to know that this is going to happen, the term is going to change to, it won't remain as MAFLD. Our MAFLD will not be there anymore. A new term MASLD will be there, will be muscled in. This editorial came in. And what did it say? That it will divide the hepatologists. This is very bad. Urgent note of caution regarding the consensus process used by the ASLD and EASL. Every group, when it comes to a consensus, it divides its own cronies. Every group. Whether it was the EASL, ASLD group, whether it is a puzzle group, they got their cronies together and then they cobble up a consensus. But when the other person comes up with a consensus, they are not happy. They want to have their way, my way or the highway. I happened to barge in, or I was a gate crasher. For 2 years I fought with them and I landed up there. I landed up there as a odd person out. It helped one group in some way. I realized it later. I became a sort of a pawn. So there were meetings after meeting, 4 rounds of voting. I mean, it was so very confusing that you didn't know what you were voting for. And ultimately you had this paper. One thing good came in. I never thought I'll have a publication in hepatology. So thanks to them. I had this paper in hepatology, Hepatology, 4 or 5 papers, just on their own, they are now getting published. But this is what is happening all over, these NAFLD, and baffled. Everyone is having now 20, 30 papers on, this. So we had this new nomenclature, umbrella term, steatotic liver disease. Then you have, MASLD. Then you had METALD, you had MASL predominant, you had ALD predominant. You will get all this in your journals. Then you had alcohol associated. Then you had specific etiology SLD and cryptogenic SLD. Now in the MASL diagnostic criteria, unlike the one which, the apostle people had the MAFL, you had 1 out of 5. If you have 1 out of 5 of these, again, I would say, from where did you get this 5? Metabolic syndrome was 3 out of 5. Apostle MAFL was, 2 out of 7, and now you have 1 out of 5. God knows from where these things come up. But ultimately, just, a basic thing, what is the difference between MAFL and MASL? Name change and definition change. Name change, the F word goes away, the S word comes in. So you get destigmatized. Patient is very happy. And definition change, watered down, from 2 out of 7, it's now 1 out of 5. Let me talk about the 2 out of 7 criteria. We looked at healthy people, healthy Indians who don't have fatty liver disease. We found 1/3 in general have this. They would qualify to be having this metabolism, 2 out of 7. A call for unity published in JHEP. I am happy to be author here. Why call for unity? A call for unity is only there if there is no unity. It never comes if there is unity. Bharat Jodo. Bharat toot raha hai. So what is happening is, like the SALT treaty, that treaty is gone. You can see the fight, the way, the fight is going on in Europe, Ukraine. We had this, one thing good, we had this global research priority agenda to advance public health. So this is the only good thing which has come out, the Amrit which has come out of the Manthan. That's all. What has happened reality? What disease do I have? So the patient says, you have MASL, dear. Oh my God, now what is that? Relax, you have what you had. Only we now call it differently. But why, sir? You didn't like it, dear. The word fatty was so demeaning to you, humiliating. Did my liver tell you so, sir? Now to therapy. Therapy is very simple. Is there anything new in therapy? What we have is a Barmicide feast. For those who don't know what a Barmicide feast is, I thought everyone knew, but then when I started asking, I realized something where, you have plates served and, a guy comes, nothing inside the container. He just serves you like this. It's empty and you pretend to eat. That is what is a Barmicide feast. It's on the Arabian Nights. You see the old therapies, such abysmal reports, useless. And the ASLD practice guidance published recently says there are currently no FDA-approved medication for the treatment of NAFLD, nothing new. As good as placebo. So what you have is the same old lifestyle modification, weight optimization, manage comorbidities. But anyway, any talk on what's new cannot go on without a reference to a few. So first to OCA, kicked out. Semaglutide, a lot of you are prescribing this. This is a commentary or, a write-up published last year on the basis of last year's presentation in EASL. Very disappointing results. This is a puzzling result, trying to put a good face on these clearly disappointing findings the guy reports. Rohit Lumba presented them and said, although the primary endpoint was not met, once weekly semaglutide appeared safe and was well tolerated in patients with NASH and compensated cirrhosis. So this is what? No benefit. These are some of the new molecules. These are from the best of EASL. I'll just talk about four molecules. Now, resmetirom is there. It has, it is in the phase 3 phase. All the big people are there. Stephen Harrison, Arun Sanyal, and this has shown NASH reduction and fibrosis reduction endpoints were achieved with both doses of resmetirom. And this appeared safe and was generally well tolerated. These data support the potential for this treatment to be beneficial. Next, I would a word about Efino. PEG, very difficult to pronounce it for me also. Pegdutide for the treatment of NASH patients. This is a combination of GLP-1 and glucagon receptor coagonist. And here the results are, it led to a significantly greater reduction in the liver fat content than semaglutide, 1 mg. And it may be an effective treatment option for patients with NASH. Then I'm coming to the end very soon. Pemvidutide. This is an investigational GLP-1 glucagon dual receptor agonist. And this acts both direct effects on the GI tract and brain and also on the liver. And what they show is that this leads to rapid and potent reduction in the liver fat content, serum ALT, body weight, and is very well tolerated. Yeah, the last few slides. Then pegozafermin in the treatment of NASH patients. Now, this is the first therapy to achieve fibrosis regression and NASH resolution with a twice weekly or twice a month dosing regimen. There are currently, once again, no FDA approved medications. We have to come together and we have to prevent the disease. We have to prevent the disease. Pharmacotherapy, there is nothing much as of now. We have to take the bull by the horns. Thank you.
Hardly any time left, so I think we can invite the next speaker, Dr. Ajay Duseja. And he will be speaking on HCC and a non-cirrhotic liver.
So good afternoon, everyone. So at the outset, my sincere thanks to Professor Acharya and Professor Puri and all the members of the organizing committee. I can see there are more talks on HCC, so I have been told to be, focused on the non-cirrhotic HCC. Which we understand actually constitutes around 10 to 15% of all the HCC what we see are non-cirrhotic, which means that the HCC is happening in the background where there is no cirrhosis. Typically, when we used to talk about, HCC happening in a non-cirrhotic setting, we should always, to think about what, fibrolaminar HCC, which we know happens, in a young people like that, and usually in a non-cirrhotic background. But now, with the wave of metabolic syndrome and NAFLD or MESLD, whatever you call it, I think more and more HCC is now happening in this kind of setting, which is happening in a non-cirrhotic background. We also know hepatitis B as a very notorious in causing HCC even without cirrhosis, and maybe certain other etiologies. So I'll be dwelling upon maybe next 10, 11 minutes on some of these aspects. So just one slide on fibrolaminar, I just thought, because we really don't see it very often, but then this is our own case, what we saw only last month, a young boy around 25 years, and he had come with just pain abdomen. So, these patients, the fibrolaminar would happen in young people. Unlike the conventional HCC, they have equal gender kind of distribution, and they will have normal alpha-fetoprotein, a typical radiology with central scar, typical histology, and, even if they come with an extensive disease, they are usually resectable because, as I said, they have a non-cirrhotic background and they carry a better prognosis in comparison to conventional HCC. So as I said, I'll not be talking more on fibrolaminar HCC, but then we'll now focus on the conventional HCC, which is happening in a non-cirrhotic background. So the first question is that how common or how frequent is to have HCC without cirrhosis. So I'll show you some data on this. This is one of the largest data, five large centers from US, 5,000 patients with HCC. Around 12% of them were, HCC without underlying cirrhosis. And when they looked at the characteristics of these patients, these patients were older, more commonly females, less frequently black, and NAFLD was the most common etiology in them, around 27%, followed by viral. We don't really see Hep C in the setting, without cirrhosis, but this study found that, and followed by Hep B. In addition, most of these patients, because they are happening in a non-cirrhotic, they are not on the regular surveillance program. So when they come in, they are subjected more frequently to resection, and overall people feel that they still carry, even if they come with multiple tumors, even if they come with large tumors, their survival may be better than, the HCC happening in a cirrhotic background. Another study, again, a large study from US, around 1,200 patients, they had HCC in the setting of cirrhosis. 20% were here, without cirrhosis. But again, if you look at, the etiologies here, it was the metabolic syndrome and NAFLD and not the alcohol and Hep C, which was causing HCC in a non-cirrhotic background. And to the extent that NAFLD and metabolic syndrome had 5-fold increased risk of having HCC in a non-cirrhotic background. So I think this is all boiling down to metabolic syndrome, NAFLD. And again, confirming the same thing, this is another study which actually compared the non-cirrhotic versus the cirrhotic HCC. And look at this, the number of nodules higher in a non-cirrhotic background, the larger tumors in a non-cirrhotic background, because as I said, these patients are not on surveillance. And finally, the treatment usually is a resection, less commonly, other modalities, but yes, we'll discuss some of these also, but more commonly they're subjected to resection. But another point, I think normally when we talk about, say, non-cirrhotic background, our impression in journal is, and which is also probably true in clinical practice, is that even if we call them as non-cirrhotic, I think majority of them will have some kind of fibrosis. It could be F2, F3, if not F4. But this particular study actually said that it can actually also happen in F0, which means only fat in the liver and no fibrosis, and still, having HCC. The numbers were small, but as I said, in clinical practice, we will see, more often in a non-cirrhotic livers also some amount of fibrosis, maybe F2, F3, but not amounting to, cirrhosis. Now, how about, the non-cirrhotic, HCC happening in other etiologies? This is a meta-analysis of, a large number of studies and very large number of participants. Again, majority of them had cirrhosis, background. But then when they compared the 14%, those who were non-cirrhotic, and when they tried to look at the etiologies in them, again, majority of, non-cirrhotic HCC were happening in NASH, which was 38%, and in other etiologies, it was 14%. So, other etiologies can also have HCC in the non-cirrhotic background, but then NASH, they have, greater odds, maybe twice more risk than other etiologies for having, HCC in a non-cirrhotic background. So what is the Indian data on this? Again, I think this is one of the largest studies, a multi-center study, which, PGI, AIMS, ILBS, most of these centers were part of it. And, this is around 2,600 patients published recently. 28% here were non-cirrhotic. And if you look at the cirrhotic versus non-cirrhotic here, again, it is the NAFLD, which is 48% constituting for non-cirrhotic HCC, followed by hepatitis B, which is around 20%. So again, I think giving us the same message that, and this is our own data, which we published 2 years back, around 870 patients. Again, when we looked at our patients, 86% of our patients did have underlying cirrhosis, 14% were non-cirrhotic, and within the non-cirrhotic, hepatitis B, followed by NASH. These were the two common etiologies for non-cirrhotic, So I think the first message, as I said, is that around 15% of, HCC can happen in non-cirrhotic background, and two etiologies which are more common in our setup. One would be hepatitis B and second would be NASH. So this is one study on hepatitis B as, in a non-cirrhotic, HCC. And again, within that, though the numbers were not very high, but within that they said that the non-cirrhotic hepatitis B would tend to occur in non-whites, which means more of Asians or maybe African Americans, and those who have family history of HCC. So that was the, typically, the hepatitis B related non-cirrhotic, HCC would happen. Pathogenesis, the time will not permit me to get into the details of the non-cirrhotic HCC, but it is basically boiling down to whether it is hepatitis B or metabolic syndrome. Ultimately, what kind of signals are kind of activated, what kind of gene alterations which are happening, and which leads on to cellular proliferation, either through the route of cellular injury, cytokines, inflammation, fibrosis, or even without that. And it is basically leading on to HCC and various, genes getting activated here. Last few minutes about the treatment of, non-cirrhotic HCC, having a, non-cirrhotic liver. We have had patients, those who actually had post-resection or post-hepatectomy liver failure, which means that the background liver, even though looked non-cirrhotic, actually had some amount of fibrosis. And depending upon the remnant volume, many of these patients will not tolerate that and will go into what we call the post-hepatectomy liver failure. Then transplant can also be done for these patients and as a rescue therapy, those who have had recurrence after the resection, or even as a primary treatment. For patients with, non-cirrhotic liver, those who are not resectable, this is one study from the European Liver Transplant Registry where they had transplanted these small number of patients, as a primary treatment or even as a rescue therapy for intrahepatic recurrence. I think that's possible. How about the other modalities? Now it's the era of, the systemic therapy and the immune checkpoint inhibitors, and we will have one session in the evening today. But overall, again, there is not much data on the loco-regional treatment and the other, but yes, we can follow the same BCLC regimen in these patients also and give them that kind of treatment. Regarding the immune checkpoint inhibitors, specifically, there is no good data in non-cirrhotics, but in general, we have data to say that these may be less efficacious in non-viral etiology, which means they may be less efficacious in NASH as the etiology, and which we know is the most common cause for non-cirrhotic, HCC. So this is which actually gave us this answer. Final, question is about the surveillance, because as I said, these patients come as big tumors, multiple tumors, because they are not under surveillance. So what should you do? HCC is high, and in comparison to, those who have low FIF4, those with high FIF4,